Okay, welcome everybody. Here we are at Living Hasidus. I've given this introduction and I want to say it one more time that we are so lucky to have information here and available in a time even before many women are pregnant or even before they're even married. And we try to give it in a time when you can think and process and you're not pressured by. And so we really make the space open and available. And usually by the end, it's packed full of people who are like filled with questions. So I want to first and foremost, I want to thank give me 1 second. Doot. Here we go. Tonight is generously sponsored by our anonymous donor for Refuah Shlema for a speedy recovery for Rivka Amitza Bas Sarah. Also, today in Israel, 2 Chabad soldiers passed, and I don't know their names. I just heard about it on my way here. So I want to also do it in schos for them, Elias and Neshama, and only good things for their family. We should be reunited with our loved ones right now. So with that, there's a beautiful relationship that a parent makes and a woman has to her birth and to her how she feels at a birth, what happens before the birth. And so we at Living Chassidus do classes to really bring that information, to really give you guys the tools. And even for myself, I've, thank God, done 5 home births. They've all been amazing, magical, incredible. And I just can't wait to share the beauty of birth with everybody. So tonight we have the most amazing Cara Muhlhahn. She's a certified nurse midwife. And not only, let's just start, like she's famous because she changed all of our lives with an incredible The Business of Being Born documentary. Also changed my life and my husband, and it just really put us in the right path. So thank you so much for doing that. She's a graduate of Columbia University School of Nursing and SUNY Downstate Health Science Center in Brooklyn's midwifery education program. Prior to starting her private practice in 1996, Cara practiced midwifery at Beth Israel Medical Center and at Maternity Center Inc., Manhattan's birthing center, both in New York. So thank you so much for being here. And I got to do a birth with Cara, so I was very lucky. It was very special. So would you, if you can clip it, if not,
okay, fine.
Yes,
Look, I have something that's probably going to create interference. Let me put this. It's a telephone thing. Hold on.
Okay, good.
Yeah. Okay. Yeah. Where do we clip?
Just
like here.
Yeah.
Okay, got it. I got it. I have been on. Should I start?
Yeah, go for it.
Okay.
Oh, I also want to share, there's index cards with pens. If you want to submit some questions, send them up.
I just wanted people to have the option to ask anonymous questions that no one, because birth can be a private matter and the questions can be complicated, and I wanted to avail myself to answer them without outing anyone. So that's why I asked Mihala if she would have that. So, I mean, this is going to be a free-for-all. I can already tell by this is the enthusiasm of everybody here, but I did try to structure a talk just based on introducing you guys to the concept of physiologic birth versus active management of labor. And that is going to lead us into how the different settings compare in terms of why women are less likely to obtain physiologic birth and why they're more likely to end up with a 33 to 2022, the cesarean section rate in New York City was 33.9%, which is very, very sad. Now I have a bias towards home birth, but you read some of my background and I wanted to give you a little more so that you can know that I have practiced in hospital as a midwife. I practiced as a labor room nurse for 5 years, which was amazing training in terms of clinical skills like starting IVs and, emergency things that you learn. All the labor and delivery nurses start all the IVs. So some of the midwives that haven't had that training, then when they're in an emergency situation, they haven't been doing it for 5 years. So I'm so grateful for that nursing training, even though current education doesn't require it. And that's okay. That's okay.
It does or does not?
It does not. You can be a CM in New York, not in the national certification is certified nurse midwifery, but there are a lot of states that allow CMs. Like Tanya Z is a CM, certified midwife. She can prescribe, she can do everything. And she worked in a hospital, so she probably has experience starting IVs. And I can't comment on everybody's experience, but I just know that I'm grateful for my nursing experience because it makes me feel very competent when I have to do something really quick like that. So, so I worked at the maternity center for 4 years, and I did that after nursing school and midwifery school. I did that because I wanted to gain the clinical expertise, because I felt like I was going to be out on my own as a nurse midwife, alone in the field with potentially a complication. And I wanted to know that I'd handled everything. So I waited to leave there until I had done 1 shoulder dystocia, 1 neonatal resuscitation, 1 PPH, maybe more postpartum hemorrhage. But that was like, I had this criteria. And then because you guys, and you can interrupt me anytime, we all know that fear is palpable and that fear has an influence. And we have to mitigate fear with data and good skills, but sometimes fear can overcome a situation and have a negative deleterious effect and even affect clinical outcomes. I mean, I'll give you, can I digress a little bit?
Yeah.
Like I made these cards so that I wouldn't digress, but the way we started this talk, we're all over the place, which is fine with me. That'll work. So one of the first babies I delivered during COVID, actually, it ended up being in a magazine. What was the National Geographic? Did you see that spread? It was terrifying. So the photographer had wanted me to sign some kind of a consent that I would allow everything to be published. And because I've had experience with the press before, I said, no, that's okay. I'll sign it when we're all done. Interestingly enough, it was a second-time mom. Everything was fine. Labor was going fast. Fluid was clear. Water broke. She had a doula there who is a very competent doula, who was the one who she relied on because she'd had her hospital birth with her. So to do home birth, it was her first time. The baby came out, 0 APGARs. Nothing. So I had to do a full-blown resuscitation. Yeah, the baby wasn't breathing or moving or anything. It was, basically headed in the wrong direction unless there were a qualified attendant there. So that baby had no risk. And we know that 10% of babies, that's the stat, may need respiratory assistance at a birth. So I remember this resuscitation well, because it's not the only one I've done. And I remember being like 3.5 minutes went by, the entire room was silent. There was the birth mother, the father, the parents, and the toddler. Wow. Total silence while I'm working on this baby. And I remember this wave of fear as soon as, because usually you do 3 breaths and then the baby should do something. Like if the baby just goes, you're like, okay, we're good. If the baby doesn't, you have to move to CPR. You have to, you have to step it up a little, which I did. But I remember after the baby didn't immediately respond, I got possessed with fear. And I did this thing psychological. I'm no room. Like you can't do that. That's not part of what we're doing. We're not doing that. We're doing resuscitation. And that's my inside. That's the inside of a midwife. A woman giving birth usually doesn't feel that because she's so working so hard. The contractions and the pushing and so I've learned very strongly that fear is not good. It's not good. It doesn't make you think better. It doesn't make you act better. And so I completely divorced myself from that fear, that wave that wanted to engulf me. I'm like, no, we're just going to do this. It's good. And the baby came around, the baby screamed, the whole room went, yay. And I was like, And a baby like that, I should have, this is something you need to know before you move out of a protected environment where there are other trained professionals that could do that if you can't, like a new midwife being, I should be able to do that because a baby that it does not experience prolonged distress, which means oxygen deprivation over time, decelerations, problems with the heart rate, a baby that doesn't have that over time should be able to be resuscitated at home. It's a kind of an interesting thing. And I hate to start with the the complications first, but we just ended up here. Like a baby that has had multiple decelerations, a long labor, problems, meconium, that baby's more likely to need hospital type resuscitation that involves medication. And it's nice to have a lot of people to do that. But this kid was fine. So I should be able to do that. I should be, and I did. But that was such a lesson in how fear is not good at all. Hello. So I brought these little cards because I was up all night. So I figured in case I have to refer to my cards, you guys will forgive me if I fumble too. Okay, so in the US, I just wanted to specify that it's not like it is everywhere in the world. So we have birthing centers, although very few. The Brooklyn one keeps opening and closing. Morris Heights is still there, I believe, in the Bronx. I worked in a birthing center that Woody Allen bought the building, it closed and sold the childbearing center to St. Vincent's, which then sold it on. But so birthing centers have a little bit of a trouble with financial viability. So they're always going defunct, sadly, because a lot of women might approach a more natural birth by first trusting an institution, such as a birthing center that has more rules and regulations, it's more policy based than is someone practicing at home. So it gives a lot of women the confidence to exit the hospital if they can go to birthing center. So I really feel sad that there aren't a lot of birthing centers in New York. But it's mostly a financial thing and a liability thing. So in other countries, like I just want to give you the example of 2 other countries because it's interesting. Denmark, for example, the midwives in hospital use intermittent auscultation, which is what we use at home with a Doppler. So that doesn't appear abnormal. Hospital birth, when you listen to the baby's heart rate with a Doppler, like at a prenatal visit, you take the Doppler and you listen. But here in the United States, it's typical to use electronic fetal monitoring to hook everybody up to the monitor. And so people end up understanding that that's safer. It's not actually. It makes for more cesarean sections and the perinatal morbidity and mortality rate isn't better. So they know that. They've done that study thousands of times. But the comfort level of the way residents are trained and what women see makes them rely on that as a comfort level. So I just want to let you guys know that in a country where most of the babies are born in the hospital, like Denmark, they don't do that. They only do that for someone who may be hypertensive, post-dates, bigger babies, something where they're concerned, they're concerned about that this might develop complications. But for normal people, the women walk around in labor, they don't change into a gown. The midwives, they're not in the room all the time. Same in the UK, they pop in once in a while. They're like, how are you doing? The woman in the UK has nitrous in the wall. She takes it on her own. The family's sitting in the room. So they have birth that is more family oriented in a lot of other countries in here. And in a way, it's sad that hospitals can't provide that here, because I would love to practice like that with a cesarean section down the hall. Because that's 3 minutes, not 20 minutes or 10 minutes. I mean, New York City is very great because there's a hospital on every street corner. You're mostly, I'm not in rural Montana in the mountains with a pickup truck for a transport vehicle. And there are places like that, like in Nicaragua, where you're like, just go to the birthing center because it's going to take too long if something happens for you to get emergency help. So I feel great practicing in New York. And I think anybody who is thinking about having a home birth can consider that factor in. The transfer, ACNM, American College of Nurse and Midwives, said you should be 30 minutes from a hospital, but 10 minutes is even nicer. I mean, here you've got Methodist, then you've got, what's the one on Flushing and Broadway, Woodhull, and then you've got MIMO, but that's a little further. They're so close, and they can all do emergency care as need be. Nobody really wants emergency care. So I just wanted to let you guys know that other countries are not really the same. And sadly, culturally, that has created in the United States, at least in New York, where we live, like a divisive turf war type of a feeling between different obstetrical providers. So OBs will say, oh, home birth isn't safe. And in Denmark, the woman sees first a GP, then she has all her care with the midwife, and the woman decides where she wants to have the baby. If she wants to have the baby at home, but I shadowed a home birth midwife in Denmark. What happens is the midwife calls the hospital, they deliver the big kit, which I have the kit in my car, drive around with it all the time. The taxi delivers the kit. with all resuscitation equipment and everything. And that's how they do it. So the society embraces it. And it's the mother's choice, which is lovely. And it's just interesting to know, because really every woman needs to do what they feel comfortable with. But the way you're going, the best chance you have of having an empowered physiologic birth is without policy created, protocol-based routine interventions. And that's what I wanted to highlight on this talk. What are we after, really? It's not so, I don't want to demonize the hospital. It's not going to serve any purpose. I want to lay out for you, what are we after? We want you to have physiologic birth. And I want to read this definition because it'll be better than mine. It's a short statement. Normal physiologic childbirth is characterized by spontaneous onset and progression of labor, no induction. Includes biological and psychological conditions that promote effective labor. So if the woman's anxious, like my client who broke her water on the 20th at night, didn't have the baby till this morning at 3:33 a.m., she was very anxious, even though she's always had her water break first, but for some reason she was, this baby was flipping back and forth. It was breech 1 week, vertex the next week. So it just created it. It was just like unseated, literally and figuratively, this kid unseated her entire comfort level. So, but I checked on her regularly, listened to the baby, did non-stress tests, and left her. And I said, is something going on? Are you okay? And she said, I don't know, I'm battling. I just need time to work through my emotions. Like, we actually had this conversation. So the only fix for her to progress wasn't medication in an IV to move forward. It was like she needed to work something out, and she did. And I gave her the added support she needed by checking on the baby so frequently and saying, this baby's fine. We're having accelerations. The fluid's clear. We should be good. And I said, are you nervous? Because if and she's like, no, I'm not nervous. So we had an opportunity to factor out the fear, to acknowledge that could exist, and to put in whatever mechanism we needed to create a comfortable environment for her so she could have physiologic birth. What finally happened, I was there many, many times from the 20th. What finally happened was last night, and I slept in the car outside her house for one night. Nothing happened. It's fine.
I heard that you.
Yeah, I was going to take a picture. No, it doesn't work as well when you watch people. They all invite me in.
The pot doesn't boil when anything wants.
It does not work. I was going to take a picture of you guys just for humor. I still haven't rolled up the mattress in the back of my bed. I was going to take a picture of that. But, she finally called me last night at 2:20, and she said, okay, now finally she had a pattern. Otherwise she had a contraction here. Hours, the entire day, she had a contraction every hour. It was posterior. That's why sometimes the water breaks first when the baby's posterior, so it's not well applied to the cervix, so it takes a while to come down. And then 2:20, so I didn't even race over. I'm like, good, I'm on my way, but I didn't delay. I put my shoes on. I put my womb, ran out the door because I'm fast, and I got there at 2:20, and I'm in East Village, and she's over here in Crown Heights. I got there at 3:19. I wrote my first note. I was getting things ready. 3:33, she had the baby. Boom. But she needed those 2 days, and the baby needed that time. And as long as that baby was safe, that is a perfect example of physiologic birth. I never told her to push. I never told her she was 10. I never examined her because her water was broken for many hours. She was GBS negative, which means less chance of that bacteria affecting the baby. And she was comfortable about those things. That's physiologic birth. I never told her to push. She's like, I think the baby's coming. And her husband was filling up the pool. We never got in. We squatted down at the side of the pool, and boom, out came the baby. Wow. So for every woman, if you have the opportunity to experience the empowerment of watching your body, it's not easy. It's not easy to give birth. It's hard. It's painful. We go through things emotional and physical, but in the end, when you come out of that, the other side of that, you don't go, thank you, Dr. Lamaze. You're like, wow. And all of us are there. Wow. Grateful, joyous, humbled, but reinforcing the fact that physiologic birth is the way it's supposed to be. We've got lots of interventions we can do. if there's a problem. But can we at least aim and create an environment where we can get physiologic birth? So includes blah, 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 results in the vaginal birth of infant and placenta, results in physiologic blood loss. I want to address this before I forget, because I may digress. You know, in hospitals, most people have an IV. It's routine, and they get Pitocin to make sure that someone doesn't have a hemorrhage. Now, there is an association between oxytocin, which is our natural Pitocin. Synthetic Pitocin is a synthetic form of what we naturally have inside of us, the love hormone. So when a baby is born and comes out and the mother sees it, and it's so beautiful and so cute, and she's so happy to be over with labor, and it's so lovely. That is, they say that oxytocin, that is the highest rush of oxytocin we will ever have in our lives, higher than it when we have orgasm, higher than, unless you have orgasmic birth, that would be a double whammy, which I said I've seen 2 in 40 years. So I don't want to set the bar that high for everyone. But so what I've noticed over years and years of laying back, I have Pitocin, I have misoprostol, I have hands, I can manually remove the placenta. I can actively manage a hemorrhage. But what I've seen is if you don't stick your hands there, start playing with the placenta, take the baby to the Kreiselman, because we need to check it. No, the baby's here. The mother's holding it close to her bosom, looking. Babies can see 8 inches in front of their face, looking, responding. The mother gets that full, guess what? She gets her natural flow of oxytocin. Guess what? She doesn't need Pitocin. Okay, I have that stuff. I'm not going to have magical thinking and think that, oh, it's always going to work that way. Sometimes people will have a postpartum hemorrhage and I need to be prepared to handle it, and fine. But I still truly know that physiologic birth will give that woman that advantage. So if I don't interfere in that process, she's more likely not to hemorrhage. It's interesting because I just had a conversation with, we were talking about this midwife. She's a lovely midwife. She had many years of hospital experience and now she's working at home. And she said to me, we learn in school, in midwifery school, that when women have, when they're grand multiples, which many of women in your community are, you guys have a lot of babies. So people have had 5 and 6 and 7 and 8 babies. So they teach you in school, midwifery school, that when you have that many babies, you're more likely to hemorrhage. I have so not seen it, but they plant that seed in the clinicians so that they're nervous and they're giving you the pit because they're saying, oh, she's a grand multip, she's a grand multip, she's going to bleed. And so this midwife said to me, you know, I've had a couple of hemorrhages recently. How do you deal with that in grand multips? Because she just started working more in your community. I told her that when I really believe and trust physiologic birth, not to the fault of not watching and treating unnecessary hemorrhage, but when I see that, I have less. And when women have a lot of babies, oftentimes they don't want to feed the baby right away. And anyone here who's had a lot of babies knows why. You get killer cramps. And so like, oh, that baby's so cute. It's not hungry though. It's not. It's not hungry. However, that mechanism, the baby wants to nurse. It's like, it's a reflex. You touch it here, it tries to nurse. It tries to nurse on the dad. If the dad's doing skin to skin, that baby wants to nurse. And when that baby nurses, the mother's uterus contracts. So I said that to her, I know why some women want to nurse. I understand. So let's talk at a prenatal visit about, let's get the hot water bottle ready. Let's talk about if you want to do a med to deal with the pain, because they're going to come when you nurse afterwards. But then, and she said she did it and it was great. Maybe that was just the luck of the draw. I don't know that was causal in any way, but I do think that trusting physiologic birth makes a huge, huge difference, aside from what everyone is looking for: control, satisfaction, to be left alone, to trust the body, and to have a non-interventionist birth, which is kind of what our birthright is. And I think every woman, when they think about birth, they don't say a woman has a baby and she's already, and no one tells her a horror story about the hospital. She thinks she's going to go and have contractions and push a baby out. She doesn't think she's going to get checked every 2 hours. She doesn't think she's getting an IV. She doesn't think she's going to be hooked up to a monitor. That just starts happening to her. And then she gets taken out of herself and she doesn't have her flow any longer. Whereas if I have a woman at home in the dark, I can hear a heartbeat in the dark. I just put the Doppler on and listen, and it goes in the water too. And we have to check the heartbeat. We have to know this baby's doing fine. So, we're creating that emotional ambiance for the mother to be able to flow. And if she can flow and do what her body tells her, so many women, I don't tell them where to lay. Here's a really fun story from COVID days. This woman had 10 babies in the hospital. And then it was COVID. I said, why are you having this one at home? She said, I don't want to wear a mask. I'm like, okay, I get it. I wasn't going to make her wear a mask. She's having a baby. So, but when she was in active labor, she said to me, we gathered together a little birth kit and some supplies. And one of the supplies is either a shower curtain liner or a vinyl coated tablecloth, kind of like this, a little thicker. We keep that as a drop cloth so that wherever the woman has the baby, I put it down. She might drop down on the floor on hands and knees. I've had a couple of babies on the toilet recently, not in the toilet, on the toilet, distinction made. So, no, why would I move her? Why would I move her? For my own comfort? No, she just goes like this. I'm down here in front of the toilet. I take the baby and hand it to her. Doesn't have need to go in the toilet. But everyone knows who's had a baby that when you sit on the toilet, it feels exactly like what you're doing when you push a baby out. Yeah. So, so what was I saying about the thing, the cloth? This is what I'm afraid of because I didn't sleep last night. What?
The story of a woman who was giving birth.
Oh, so she said, so aren't you going to put the thing on the bed so I can push the baby? Aren't you going to check me and tell me I'm 10? When someone's having physiologic birth, I don't need to check her. I can tell by what she's doing. She's going, I'm like, oh, that kid's down there. Whoa. So she said, and I want to tell you another story because the stories are the best telling of the truth. So I said, well, some women, and this is a woman in labor, and I don't want to shock her, and I don't want to do anything that's going to upset her. I said, well, some women have the baby standing. Some women sit on the toilet. Some women go on the bed. Wherever you go, I'm going to put this. So in other words, if she wanted to lay on the bed, I'm not here like, oh, we're home birth. We don't do lip birth on the bed. She can have the baby on the bed, but I just wanted to just tweak that opening just a little bit. She had her baby standing up, leaning on the bed. And afterwards, I asked her, I said, how was it? She goes, much easier pushing because gravity does the work. It was her 11th baby. So those other babies had done some of the work too. I was behind her. I caught the baby. Here was the bed with a little towel on and a chuck. I just put it through her legs and laid it on the bed. And she got to have that happen to her. And she got to be moved and expanded and feel like, wow, my body did that. I did not tell her what to do. And, the problem, experts are good for some things, but the problem, the reason that I'm a midwife and the reason that I do home birth, and because like I said, sometimes it would be nice to have a cesarean section down the hall where you absolutely have to have no thought that if anything goes wrong, you're far from help. But is because the only way to get that is to leave a woman to her own devices. And in the hospital, there's just too much active management, which is what I'm contrasting with physiologic birth active management. Like if in the hospital or in any active setting where they do active management of labor, if you do exams every 2 to 4 hours, you are asking a woman's body to respond to the Friedman curve. That's an old thing. It's a Friedman curve. You learn about it in midwifery school that a multip should dilate however many centimeters an hour and a primip should dilate so however many centimeters an hour. If not, they need to be moved along with PIT. That's why there's so much Pitocin. I mean, what I did with her was she had contractions on and off all day. I said, because the kid's posterior, as soon as it turns, it's going to come out. And we had a feeling the cord was around the neck because that baby had been breached 1 week, vertex the next, head down the next week. I'm like, this kid is like having a tough time in there. And probably she didn't want to make, it was a little girl, so cute. She came out perfect. She probably didn't want to make her final descent because I don't remember the cord being really short, but if the cord was short, maybe it would have stressed her. So at the last minute, she just had 5 minutes of descent and came out in 2 minutes. But the whole rest of the time, the head was a little bit high. And when the head's a little bit high, it's not going to press as much on the cervix, which means she's not going to have that nice regular pattern. So she had literally less than an hour of really strong labor and the baby was born. Now, I think that there's wisdom in the body and that wisdom of that child's desire for survivability, and it knew what it was doing, in some mole-like way, because when it was breached, it probably got better oxygenation. So it liked it there. It was happier there. And it probably had a feeling that when it went down and when it went that final descent, It came out, I didn't need to resuscitate it, which was great. But for a minute, she looked stunned. And Rocky was like, can I see the baby? She was here. Her Tosha was here. I was behind her. I said, just let me midwife her for a minute. I just rubbed her around. She screamed and I gave her a one. But yeah, so I'm going to lose my train of thought. Da-da-da-da-da. It's okay, because the digression is where the best things happen. All the stories. I want to tell you another one of physiologic birth. First time mom. Now, a lot of people will think if you don't examine someone and tell them they're 10, okay, first of all, nobody wants to be in labor forever. So the doctor comes in and says you're 10, you're like, great, I can push and I can get this over with. And that I understand, having been a woman in labor that, basically cried when I was 3 centimeters, made my midwife examine me because I thought I was so far along when I wasn't. What? I was a midwife, yeah. Yeah, I was. But, laboring women behave the same. It's like the knowledge goes out the window and you're just like a mammal doing your thing. So I understand that that's attractive for someone to present it to you as if you can be done. But then you see how the shift happens. Then it's like someone else gives you hope. And then you turn your hope to that other person. You look to them for help. They can't do anything for you. Whereas if you leave, okay, so here's the next experience of a first-time mom. She was actually gestationally diabetic, but her other midwife tried to give her to an MFM. And she asked me if I would take her, maternal fetal medicine specialist, high-risk doctor. And they wanted to put her on insulin. I said, listen, if you keep your numbers good, I will take you, but you have to be good. You've got 6 weeks left to go. Just do it. Make the effort. If your numbers are great, her baby was 6 pounds, 6 ounces. So she did a great job. But her mom, who had had all the home births, was with her in labor. And her mom was looking at me like in agony, watching her daughter. And I have to divorce myself from that. I can have empathy, but I can't feel agonized every time any of us feel pain in labor, because that's what it's going to be. So I'm watching the mother and I said, she's like, and I knew the mother was trying not to interfere, but I know she wanted me to check her, say she was 10 and have her start pushing. So I said to the mom, I said, if I do that, it's going to change the entire focus. She's doing her thing. She's, whoa, rolling her head, leaning on us. We're mopping the brow. And so, but to make the mom happy and also to get her delivered sooner, I said, okay, let me see if I can coax her onto the toilet. Because what do we do on the toilet our entire lives from the age of 2 onward? We know how to do that, right? It comes naturally. It's physiologic. It's natural. No one tells you how to take a dump. You don't get an instruction manual. Oh, let me see. Well, next, let me try to do that. Am I dilated enough? We had a joke in midwifery school. Next time your doctor wants to have a bowel movement, have him lay down and cut the opening to make it easier to get out. I mean, it's a good joke. But so I wanted to help her get done, and I wanted to help her mother get out of her agony. And I said, let's see if we can get her to the toilet. So I walked her over like she was really like, the baby was down there. But she wasn't pushing because it was her first baby. She was afraid of it. It hurts. It's scary. I thought I was going to die when I had my first baby. I prayed. I said, I've had a good life. You can take me now. Not getting out of it that way. So I brought her to the toilet. And then all of a sudden she's like, I feel burning. She wanted to have a water birth. So then I hobbled her back to the pool. And she went in 40 minutes in the pool. She had a baby. I never told her to push. So what has she gotten already? She had her baby. She knew how to push. It's a confidence builder. And we have to do this physical act. And really the strength comes from within. So now she's got 1 down, check, like 1 up. Now she's got 1 experience behind her where she figured it out without turning her need. We were there. She felt our support and love. We were there for her, but she didn't trade it in for an expert on the outside telling her what to do. And as a fellow woman, I feel so strongly about that element of childbearing and of being a female, So, by the way, if you guys have questions, you can interrupt, because you see that sometimes I'm going to lose my train of thought because I did not have a lot of sleep last night. But I wanted to. Okay, I guess, these stories are. Do you have questions that you want to ask me? Should I go on?
There was something you were like before you started. We were talking about the different trainings,
different types of midwives,
different settings, settings, and how that affects the decision making.
So there's that's the training of the midwives. Or
different
no.
experience.
Okay, so what I was saying, one of the things I did want to elucidate between, tell me if this is what you mean, between active management of birth and physiologic birth, is that the routine interventions that are used in active management of labor, is that what you're thinking of? Like where you give triage, and in triage they examine you and they tell you, you're 4, you should go walk. You're 7, you should not. That's not what you're talking about, right?
Talking about like different experience that different midwives have. If it's in a hospital setting, a birth center setting, home birth, it will impact the way they treat like risk management or something. You were starting to talk about that.
Well, I don't know, but I can say that having had 5 years as a labor room nurse, that has helped me to be comfortable in emergency situations. And I might say that if a midwife didn't have that experience, so in other words, if someone goes through their training and right away goes into home birth, because of course they have that ideal, and of course they want to share that ideal with women, that sooner or later, I was telling her before, because we were here before, that midwives are going to get hazed. And by that, I mean that we are going to be tested and challenged, because you have a huge responsibility for safety and to be able to be the guardian of safety. And, if you don't have a lot of experience and things get hairy. I remember when Tanya Z, who spoke in your group, and I mentored Tanya Z. So she worked with me for years. So this is not talking against Tanya Z, but she called me after she had her first real shoulder stocia. It was very, very scary for her. She was doing all the maneuvers she learned in school, and none of them were working. And it was and so the baby came out with something called an Erb's palsy, which I've had one too. Anyone who's practiced for 30 years will have one. It's when, as you're trying to deliver the baby, you yank or you pull strangely because your adrenaline is going crazy on this shoulder, and then it pulls the nerve there, and then the baby doesn't have full movement in that arm. So 85% of those resolve. Tanya's baby had that, and she was so stressed out, but her baby resolved. So she saved that baby's life by getting it out. But that was, nobody wants a baby who has a shoulder stocia.
How long does that last?
You have to watch it. A pediatrician has to watch it. How long does that, what is it called? I can't remember the name of it. How long does that anomaly last? It can last weeks or it can last your whole life. Yeah, but they have to, but 85% resolve. So most of them do resolve. But when you have a shoulder stocia, you were asking me about shoulder stocia, if you do the Gaskin maneuver, which isn't taught anywhere, which is Ina May Gaskin. I don't know if any of you have heard of her, right? I was saying that Ina May and I were I'm going to repeat this because it's so funny, that Ina May and I were on a reunion of the business being born, and Ina May was touting, yes, home birth has increased 30%. I said, yeah, Ina May, from 0.6 to 0.9. So we still have a lot of ground to cover. But so her maneuver for shoulder stocia is that you have the woman in hands and knees, and instead of doing the screw maneuver of Woods, which Tanya did, and suprapubic pressure, which is what they lay the woman back. It's called McRoberts. They yank the legs back, both of them. I'm just doing this so I don't fall over in the chair. There's another leg back here. And then someone gets up on a chair and pushes on the anterior arm, the pubic bone, and forces it under, because the shoulder stocia, when that arm gets stuck under the pubic bone. Ina May's maneuver, I had a 12-pound, 3-ounce baby that did not have any Erb's palsy. That's what it's called. Did not have an Erb's palsy because I did the Gaskin maneuver, which is, here's the mom's tush. Excuse me. We're all ladies here, which I'm so happy about. Out came this head, and I'm like, whoa, 12 pounds, 3 ounces. It was a giant head. And then, now, if you're a midwife in Northern Europe, you don't deliver the shoulders then. You wait, and there's a clip called Belgian water birth that I show all the women I want to introduce them to this concept. So what happens is the head comes out. Now I'm the baby. This is someone's sad vagina. Out comes the baby like this. It stays like that. 3 minutes and 19 seconds in this clip that I have filmed. That's normal, because contractions are every 5-6 minutes. Stays like that. This baby was born underwater. Stays like that. Stays like that. Stays like that. Still like that. Is anyone losing their breath? I can't breathe. Was it the mom dying at that point? No, because she felt relief from the head being born. Then the next surge comes. Baby goes like this. Baby goes like this. It turns a corkscrew around and comes up facing the mother, and the mother That's physiologic birth. You may have never seen that. Even I had never seen that as a midwife because they don't train you. In this country, not in Denmark. In Denmark, I sat with the midwife and it drove me crazy because I was a new midwife. The head was sitting there and the mother was there. The head was sitting there. The mother was talking to the midwife was talking to the husband. I'm like, the head there, why she's delivering the baby? And then she waited for the next contraction and out came the baby. So
in the hospital setting,
they deliver the shoulders.
They'll tell you push again.
That's right. And then, or, well, that's really bad.
I saw really bad. And what's the negative part of it?
If the baby doesn't have any fetal distress and it's fine, leave it alone. It's getting blood through the cord. It's just as if it's inside, like this woman in Belgian water birth, the baby's born under the water. She keeps it under the water. She must have read something that was good. And I'm like, right, because that's the way American clinicians, including myself, were trained, is to deliver the shoulders. The head comes out. You can cause a shoulder stocia like that because you pull down, the anterior shoulder gets stuck behind the pubic bone. So leave it alone. You see, there's a cardinal movements of labor. It's in the dance. This is because they don't know, because they think they're doing active management of labor. They think the baby needs to be delivered, which is what I'm saying. Thank you, Dr. Lamaze. I couldn't have done it without you. Hello. You could have done it. That's where all the babies born in taxi cabs. Where was Dr. Lamaze? You know, the baby came out. Doesn't mean there's no room for doctors or midwives or clinicians, but you know, so if you watch that movement, that cardinal movement of labor, it's called restitution. It has a name. The head comes out, it stays there, it restitutes, turns back to the position that it was in when it was going down. And so the head, in other words, it's in the abdomen like that. It turns around to go down the birth canal like this, and then it turns back to align with the shoulders. And then the next surge, the uterus pushes the baby down and it does that corkscrew. And people have less perineal tears that way because you're not dragging the shoulder, posterior shoulder over the perineum. It's turning and it goes inward like that. So the width is less. Beautiful. So this shoulder social gasket maneuver back. I didn't lose my train of thought. I'm so happy. No, this was, I'm just saying that I digressed and I'm saying that baby's head came out. Now there's a way that you know as a clinician when a head comes out that you may have a problem with the shoulder, because what happens is it doesn't come out all the way. Doesn't mean you necessarily have a problem, but the chin kind of gets stuck and it's not coming out like that. So you know something's keeping it. So that baby, I was like, yeah, it wasn't. It was like the perineum was here, then it was here, then it was here, and I was like, okay. So I didn't wait for her to have that lovely Belgian birth with the 12-pound, 3-ounce baby. Because as a clinician, you have to know when to act. So what the gasket maneuver is, she's in hands and knees. Here's mom's tush. I take my hand. Okay, this is the midwife. I'm the baby. So here's her tush. I'm the baby. The head's out. Now the mother's facing this way because I can't turn around. You guys won't see anything. Midwife's hand goes in, finds the axilla. It's far up. It's an entire hand in a woman's pelvis, but you're in an emergency situation. Goes like this, pulls the arm. Then the only girth you have to deliver is this. Baby just comes flopping out. You save time because if you pull, which I've done, because I've been a midwife for a long time, and when you're scared, like I said, fear is no good, and the baby doesn't come when you pull on the head, it doesn't come. Then I've been engulfed by fear. I'm only speaking from experience. It's like, of course, now I have 40 years of experience behind me, but I have caused the shoulders to almost all midwives have, by not doing the gasket maneuver. You can't pull on the nerve. If you do this, the worst you could do is dislocate the arm. Not a problem. You're not going to upset the nerve, and it didn't dislocate. The kid's fine. But so that's the maneuver that every OBGYN and midwife should use. But if a woman's laying in a bed like this, you have to get her up. She's having a baby, for God's sake. Flip her around and deliver that posterior arm. It's just too much. So they do that McRoberts maneuver with the 2 legs back and the woman pressing on here, and the screw maneuver of Woods, which I all learned in school, where you wriggle the baby back and forth, is all based on a woman in lithotomy position. If a woman is giving birth, according to physiologic, what she would do, she'll be on hands and knees. Most women drop down to the floor and push a baby out, just like the one this morning. So then there's less opportunity for that shoulder to get stuck behind the pubis. And there's more opportunity to help it out if it does, without negatively affecting the baby. So that might address your question on shoulders, Dosha. No, you, because you asked me, what do you do for shoulders, Dosha? Because she was asking me about assistance. I'm like, assistant can't help me then. I have to know what to do. Yeah, I mean, and there's moments, really. Really, most babies just come out fine. But because this is a talk, I want to touch on everything. I don't want to live in happy, magical denial. And I'm sure you guys have questions. So I'm trying to throw out lots of scenarios. But really, you know, most of the times things just go perfectly well.
Most.
Yeah.
Yeah.
Our section rate is like 1 to 2%. Another of the problems of active managed birth is that the providers don't allow woman to have the time that she needs to dilate, to have her freak out, for the baby to be posterior, not be dilating in like an anterior. They should have made a different curve, like the Friedman curve that they go by in the hospital. That's based on an anterior baby in LOA. It's not based on posterior babies. They behave completely differently.
Can you define anterior and posterior?
Yeah, anterior is when the baby's back is here. So if the back's on the left side, it's called LOA, left occiput anterior. ROA, right occiput anterior. Most babies enter the pelvis from that position. OPs usually come from ROP. The baby goes through the pelvis like this because the women's pelvis is that shape. So there's no other way for the baby to get there except for it to change shape. And you'll see the OP babies, they have like a serious cone. It almost looks like an L-shaped head. Like here's the head. And then there's a thing sticking out the back because that baby had to go down and down and down until enough of that baby's head, because it can mold, changed shape so that it could turn around and in 5 seconds come out. And that's how those babies come out. They do that. They mold for a long time. And that's what my one was doing this morning. It was posterior. And then when it flipped around, it was out seconds later. So what was I saying about posterior though? Why do you want me to define?
Just defining
Okay.
anterior, posterior.
We were saying about the low rate of C-sections and that most babies come out perfectly normal and
Right.
fine. So you were saying,
Right.
how do you?
But the pace of an anterior birth and
Is different. And that the Friedman curve which is what they use in hospitals, is used erroneously on a posterior baby. It's different baby. Oftentimes they'll break their water first. Oftentimes they'll have labor will be on and off and on. Like this woman broke her water the 20th. I don't even know what day it is because I'm underslept. 20th at 11:30 p.m. She called me. I came rushing over to make sure the baby was head down because that baby had been flipping around. And if it were breech, I would have to worry the cord would fall out. So I said, lay down, I'm coming over. I came down, baby was head down. Baby had been head down for a couple of weeks. Great, we're good. The fluid was clear. It was on the left side, but I think it was LOP. I think it was over here in the back, just by the way her labor developed. Now, to really be sure of that, all the posteriors turn around. 95% of them turn around. Once in a blue moon, you get one that comes out facing up. You had that?
I was sunny side up with
Oh!
the cord around my neck.
Oh, yeah. Well, that cord may have made you go that way. Yeah. Yeah.
Question.
Yes.
Can you talk about regular births? Like what would a regular birth look
Yeah. So it depends on which baby it is for you, a first baby, a second baby, a third baby. They're kind of different, actually. A first
like?
baby?
Let's say it's the first baby.
Okay. So a first baby is really very different from all the others. A first baby, the average, if you start young, you can have a 12-hour labor, but in general, the average is 20 hours labor. Whereas for any other, it might be 6 to 8 hours. I mean, they can teach you this in a childbirth education, but I can tell you the basics. Usually a first-time mom, the cervix, which is going to eventually dilate to 10, has to efface first, which is thinning out. The cervix is usually about 2.5 centimeters long, about an inch. And then as you have contraction after contraction that pushes the head into the cervix, it thins out the cervix. Then it will dilate. So a first-time mom, the cervix has to thin to almost like 80 to 100% before the woman will dilate. So that makes labor longer. Usually the first labor for most women is longer than any other labor But if you have a family history of fast labor, you can have a fast labor for your first one. Some people have had their babies in 6 hours or 10 hours or 3 hours, if that's their family history. But more likely, that's going to be the longest labor. So you have a latent stage of labor, which is the effacing. And then the active phase of labor is more when the contractions are stronger and you're actually dilating beyond 5 centimeters. And then you dilate about a centimeter an hour. So if you're 5, 6, 7, 8, 9, 10, this is basic. Just again, you're an individual, so it may not apply to you. And then you dilate a centimeter an hour, and then about 2 hours of pushing. That's the Friedman curve data.
I was wondering more about like you were describing a lot of different scenarios with specific births. So I was just wondering like what would a regular birth look like?
Well, so I did describe a regular birth of a first-time mom, actually. Yeah. And that's okay. She didn't break her water first. So 80% of the time the water breaks while a woman is pushing or when she's 8 centimeters. So she had contractions that she breathed through and found relief. And we put cool cloths on her face and encouraged her and had her drink fluids, many, many hours of contractions. And then she was acting as if we call it fetal ejection reflex. It's a phenomenon that women have. If the baby gets far enough down, they start bearing down almost as if they feel like they're having a bowel movement. So we moved her to the toilet so she would feel comfortable pushing. She started pushing and then she felt the baby. And I checked with a little finger. I said, oh, it's right here. And we got back into the pool and she had the baby in the pool. And then that's it. The placenta usually comes 15, 20 minutes later. Little babies come out easier. Oftentimes it's good not to have a giant baby the first time because it usually makes labor longer. After that, not necessarily. And over 10 can make labor longer or harder for the woman. But some people have 11-pound babies that come out like butter. But I would say if you're having your first baby, it's good to eat a really good diet, lots of vegetables, fruits, protein, not a lot of sweets and carbs in general. And then, have a 6 to 8 pound baby.
I have a question about patterning. Like, are posterior babies like a pattern? Would you say in your experience of observing?
So more first-time moms are likely to have a posterior baby because the pelvic bones have not been altered by birth. Women who have they have categorized different types of pelvises. So there's a gynecoid pelvis that's kind of like this. There's all kinds of hybrids. And there's the other type of pelvis, which is longer like that. That's the type where you'll usually have a posterior baby because as that baby tries to go through this way, it can't kind of fit. So that little part in the back kind of snuggles nicely in there. And it may be the shape of one's pelvis. So if you've had 2 posterior, it may be the shape of your pelvis. But I've seen many, many more babies present posterior with the first baby and not with the second. But we really don't know. And no one's x-raying pelvises anymore, thank goodness, because they did.
Is there any correlation with soft tissues?
Can you be a little more specific?
Like the psoas, the ligaments, with that in regard to baby positioning?
I probably am not well trained in that, but when I feel like if I have a woman whose baby's posterior antenatally and she wants to go to a chiropractor and get an adjustment, I always think that could be helpful because I don't really know how to evaluate what her bones are doing in there. And if he wants to, tweak her and that can make the pelvic bones more roomy, I can't see any harm in it. So yeah, but I have no way of evaluating what her ligaments are or what are you thinking? Are you thinking about a particular?
I'm thinking about like body ready method stuff.
What method?
Spinning babies.
I did spinning babies. I do yoga. I'm a dancer. I do chiropractic. I did everything.
Yeah, you probably have an android pelvis.
Every kind of somatic healing, like
acupuncture.
And the problem with that is then you have to feel like there's something wrong with you. That's just the shape of your pelvis. No, I am a firm believer. I'm very different from doulas, and I'm very happy to go on record. So, crucify me if you wish. But along with Dr. Garber, who was like one of my mentors, and his mother, Ella Garber, they both worked at BI. And I said, it's all about the bones. So what a baby does, it's how that head fits in those bones. Now, I know that a lot of doulas feel like they just put the woman on her hands and knees and she went down and did the spinning babies, and then all of a sudden it turned around and went faster. It's possible. And why not? Why not? Because a woman's in labor. If you can do anything to make it shorter, please do it. But for babies and first time moms that have to turn, I would usually lay them on their side or take them out walking and do lunges, or lift one leg if the back's on this side and have the woman lay on that side. It does kind of the same thing of coaxing that baby. But the spinning babies has you lifting the head out of the pelvis by going upside down and then hoping it'll go into a more favorable. I don't love that because you could set yourself back, but I have a very good friend who's a doula and she's like, it really worked. I'm like, great, good. Let her have a baby. You know, I don't want to get into a war about that. If you can help a woman and if it can be faster, please do it. But I'm just saying that from watching labors for the last 40 to plus years, I think that it's more about the bones, and that gives relief to you. There's nothing wrong with you. There's nothing you could have, should have, would have done. You've done it all. And that was just the shape of your pelvis.
I also want to share that something very beautiful, that sometimes we feel pain differently.
Yes.
So like there's many women that have that back pain, but it's not because there's a positioning.
No.
That's just where she's feeling.
That's a lot of women get their period in the back.
Right.
And
right.
after they have the baby and they're feeling cramps, they feel them in their back. Right. Then we put hot water about it. That's what we do.
I always thought it was position.
Right.
Like
I did too.
Baby, and that's why you have to do the spinning babies, flip your head down to position better, to make more room for the baby.
And if it works and your baby comes back. But the other thing I want to be very careful to do, it was done to women, hysteria, when women were living in such a restrictive society that they're labeling us hysterical when we weren't going along with what, the patriarchal society was saying. I don't want to pathologize women. I don't want to do it. So if you need to, like Ina May says, your body's not a lemon. You don't need to fix it. You know what I mean? But that doesn't mean sometimes you can't do a spinning baby or sometimes I can't lay like this. Sometimes I have a problem because the labor's taking forever. I'm like, let's go out for a walk and we're going to lunge and I'm going to hold you while we lunge and you're going to hate it. And we're going to do stairs, but we're not getting a cesarean. So I've been behind women doing stairs, which is a lunge, which helps as the foot lifts. It presses on the back, makes more room in the pelvic bones. I've been behind someone picking someone's cheek. Let's go for hours up and down the stairs to do anything to not have a cesarean, because that opens up the pelvic bones. So yeah, let's help. But I'm just not going to theoretically say that that's absolute,
I'm wondering what percentage of your births were cesareans at the end, if any.
So yeah, I mean, you know what? Recently, I had a para 8 who had a cesarean. She had a baby with me before, perfectly good at home. Okay. And then at a prenatal visit, there was a deceleration. I'm like, okay, you're probably just laying on the back. Let's turn over and check again. And I sent her to get a biophysical. And the doc said, Bajorni, it was Dr. Bajorni. She said, oh, there's not enough fluid here. This baby looks, well, I think this baby needs to come out. I was like, oh, because you hate when they go there. But because I had seen already evidence in a just normal prenatal visit that the baby was something unusual, I said, okay. So I stayed with her at home. We induced her at home. And as we induced her, things got really hairy. And I told her, if we induce at home and things get hairy, we're going to the hospital. I took her to Mimo. She had the most beautiful team of all women. No one wanted to section this woman, which was so lovely. So lovely. I can't remember the doc's name, but it may come to me. Beautiful.
Barlog?
No, blonde.
Yeah, Barlog.
They were all blonde over there.
Very funny.
They were all funny. It was a bunch of women.
Funny. I went pregnant to be a doula, and she was like, "No holding legs if you're pregnant." And she was like, everyone thought it was there to deliver.
They were. Oh wow! No, I'm not in labor. Doing pretty well for labor, right? Anyway, no one wanted to section her, including me. She ended up with a section because the kid was crashing and there was mech and we were standing up trying to get this baby. And then my last fantasy, as they took her in, I said, maybe my patient is just going to go rogue on the table and push this kid out. And I was hoping, I was like sending her telepathic messages. And the doctor came out after they did the section and said, oh no, we tried that on the table. We tried. She was only 3. We couldn't dilate her. Such a group of wonderful women doctors. So, I think things are changing a little bit too. And she had a really good team. And I don't know what we really felt like we got.
Okay with you going in? 'Cause, like,
Well,
you
I
guys
didn't
butt
go in.
heads
Not always though.
Oh.
We didn't butt heads at all. And I didn't go in for the section room, but I have learned being a midwife for a long time. There's a way to talk to, there's a way to communicate with people. Like I'm going in for help. So I was mostly in a doula role. I didn't talk to them about any decisions. They were like, wow, this kid looks good. Well, it was having giant decelerations, but there's still good beat to beat variability, which is just a way you assess fetal distress. Yeah, looks good. I was like, wow, these guys are amazing. And then at some point they were just like, we got to go. I'm like, I can't dispute that. I mean, it was a good call.
How did you know that the baby was under?
Because I listened to the heart rate with the Doppler.
Okay, so just through that.
Yes, that is absolutely the most important tool that in hospital, out of hospital, in Denmark with a Doppler, in a hospital here with an,
What week was she in?
yeah, but 2 days past her due date. She was term.
Oh.
We'd already had a beautiful, she had 7 other kids, one of them with me at home.
How did you induce her?
So there's lots of ways of inducing at home. One of them is castor oil, which I took because my water was broken first. I took it 72 hours. I had a baby after my water broke.
Wow.
Yeah. So castor oil is one method. There's also a hormonal method that they use in the hospital, but we can use it at home by just drinking little bits of it. Some people use blue and black cohosh. There's lots of things to do. You can give someone an enema that can help start things along. Castor oil is really good, actually, strangely enough. Well, you have to administer it properly. I mean, if you... So I spent many years tweaking the proportions, the dosage, because they'll tell you 4 ounces, which is like rabid shits you're going to get, and it's not going to be fun at all. And I don't even think it's good for a baby. Yeah, and I also think it makes women more likely to hemorrhage because it makes you have contractions that are not hormonally rooted. And then what happens in the 3rd stage with the placenta? Yeah, it can. So if you give too much. So I don't love castor oil always. That's one of the problems, but I give 2 ounces if it's really like I've had. I don't know. There's no exact recipe. Some people make it with popcorn. I usually do a shake and I have them make a shake before they go to bed. I'll give you a couple of examples. So say we decide it's not urgent to induce, but we need to induce because it's not urgent, it's not dangerous, but for some reason we need to get the baby out we have 24 hours. So I might let the woman go to sleep, make a shake before she goes to sleep. Then when she wakes up at 3 and takes it, she takes only like 6 ounces of shake, pours the castor oil in when it's mixing so it doesn't stick to the sides, and it emulsifies and it breaks down the fat globules and it makes easier for to be digested and to be taken in so it'll work. But if it's an urgent concern, like I had somebody I've had 3 people in 40 years that had anhydramnios, which is no amniotic fluid. Like we're sending someone for a biophysical profile just to check on the baby. We're expecting everything to come out good. No fluid. Every single one of those people that I induced was out. One, it took 24 hours to get her out. I moved in with her. We did breast pump. We did castor oil. We did everything. And I lived with her literally so that I could make sure that baby was fine because they're saying this baby could have a potential for distress because there's no fluid. I'm like, that's okay. I'm living with her. Literally. I lived with her for 24 hours. Every 30 minutes, I checked that kid. Kid came out, 1 tablespoon of pneumonia. They were right. So it was good we got that baby out. So we used lots of induction methods, whatever works, kind of. I think we also used castor oil and the breast pump on that one. And combined, they were brilliant.
So you said when you do need to get things started sooner, how much castor oil is that?
2 ounces.
The same 2 ounces.
Yeah.
If you're doing something differently in that case, like if it's
No. I just wouldn't wait till 3 a.m. to give it.
Oh.
Maybe I was saying because it's nice to let a woman have her night's sleep. And if you're gonna play with stuff, if you're gonna play with stuff, have her have some nice sleep. Everybody wakes up to pee at 3 a.m. Take the stuff. Sometimes it takes 6 hours to work, so you're not watching it to see if it'll work. Yes.
How are you?
Oh, sorry. I keep saying yes to you, and she has a question. No, it's you, right? You had a question. So we can use it mostly for postpartum hemorrhage, and we just put it in the cheek. Yeah, which is nice because they tell you to put it in the rectum. The first time I did that to my friend, I'm like, I'm never doing that again. I was just following the protocol. I put 800 milligrams up her butt, and she stopped hemorrhaging. But I'm like, I'm never doing that again. Now I put it in the cheek. because it doesn't really matter. It gets absorbed through the mucous membranes as fast through the rectum, and it goes through the blood. It causes the uterus to contract, not, it doesn't go locally to the uterus, so it doesn't matter. It's just as fast. Yeah, we use it.
What are tools that someone could use or questions that you would recommend someone ask their midwife when they're looking for a midwife?
Yeah, really, a pregnant woman, like we've been touching on this all along, that we usually have very strong intuitions. So I would trust your intuitions, and then you might want to try to understand that a midwife who's going to attend you at home has had ample experience without making her feel threatened, and without, and it's hard to know what types of questions to ask. I mean, how many babies you've had doesn't necessarily tell you. So to try to find some kind of a way to ask about her experience, because I think, really speaking as almost like an elder midwife, like I said, I've had a shoulder dystocia. I've had all of the things that midwives are going to get hazed by. And now my judgment, I was always smart and good and conscientious, but now my judgment is so honed that I know that we need to go or we don't need to go within seconds. Like when that person, the para 8 who had the section, I'm like, we're going. That's it. We got to go. This kid it's going to get worse, and we're not having a baby at home. So I'm not wasting any time. But I had another case where a baby had fetal distress. It was her second baby with me. First one was born at home. Beautiful. Second one, she got COVID like a week before she went into labor. She was 41 weeks, not so late. And the doula said, I don't think we need you yet. And I said, yeah, I'm just going to go and listen to the baby. I had an instinct, because I too trust my intuition, when it speaks to me. I listened, the kid was tachycardic. Now, that just means the heart rate's fast. Sometimes it means you have a fever. Sometimes it means you're dehydrated. Sometimes it means the baby's moving. And sometimes it means the baby's experiencing distress. So I had to rule out all of those things. And I said, it's distress. So I said, okay, I never did this before. At that point, if I were a younger midwife, I would say, we need to go. And I've done that. I've transferred someone with fetal distress with tachycardia. I took her to the hospital. This one, I said, okay, I think I have one move left we can do. I said, I'm going to examine you, which again, I don't do routine exams. I'm going to examine you. And if you're ready to push a baby out, I will just dilate either way. We'll push the baby out, we'll get it done, and the baby will be fine. If not, she wasn't. She was only 3. So, and it was her second baby, so she could have gone really quickly. So I said, okay, here's what I'm going to do. Inside her, I pushed the baby's head up, and I said, maybe that baby's laying on its cord. Maybe it's wrapped on its cord, and every time she has a contraction, it presses on the cord. So she would have decelerations or tachycardia or some signs of fetal distress that I could note with the Doppler, with listening to the fetal heart rate. So I pushed it up. The tachycardia went away. I felt like, wow, amazing. We didn't transfer her. She had a baby, perfectly fine. So no, like 2 hours, not 20 minutes. And the whole time I was checking the baby after that, because now I've got a concern. I'm like, I'm not sure the kid's making me feel good. Like the one this morning, I kept telling her, the baby's great. Don't worry that you're ruptured. It's fine. This baby's perfect. But it's like what's grown is because many times as a younger midwife, I took someone in and they ended up having a vacuum because we're worried about the baby. And it's such a violent birth. And I saved her from that, but also protected the baby. So I know how life-saving, I know, because the medical profession is filled with people, we call it a messianic complex. It's both good and bad. I have it too, but I've spent many years, battling with mine. Yeah, well, well, for healthcare providers. Are you leaving? Oh, okay. Do we need a break?
No.
We might need a break. No? I know. Oh, look, of course you do.
Go ahead.
Have I answered your questions first time, Mom? Am I making it?
I'm not a mom yet.
But you're thinking that one day you will be, which is lovely. Do you know anything about, well, I don't want to put you on the spot, but a good way to get information about how birth may go for you is to talk to your moms and sisters, because it's often carries through. No, not if they had cesareans. It could have been obstetrical malpractice. It could have been just because our cesarean section rate is now 34%. Okay, all right, I retract that then.
How are you still available for 24 hours?
You know, it's a very devotional. I don't have a lot of children. I have one, and now he's grown. When he was young, I had an on-call babysitter all the time. And I was just talking to Miriam about this. You have to really, this is not a job. It is an ideological, it's a devotional career. It's not a job. It is, I am devoted to making birth better for women and babies. And then you will do that. You're moved to that. It's not hard. Like the one last night, I'm like, I'm not pushing her. I said, when she said, I said, is something going on? I said, you seem a little anxious. And we'd had 2 kids together before. She said, I'm just trying to work through something. I'm like, well, I'm not going to push you. At home, you have time to work it through, as long as your baby's fine, you know? And it was, her baby was fine. But you have to understand, like, you know, you've had a child, right? Okay. So, but when you do, that love and satisfaction, empowerment you get is so amazing. And when you do it physiologically, it's even more amazing. And so I get to experience that reward from having facilitated that and not stolen that from you. I mean, I've seen doctors, I'll never forget, and I'm naming this guy, Dr. Julowitz at Columbia Presbyterian Hospital. I was a labor nurse there for 5 years. Grand multiple woman who's had 8 or 9 kids, probably a Jewish woman who's had 8 or 9 kids. She knows how to have a baby. He checks her. She's 10, get the vacuum. He vacuumed out the kid because he felt like it. Or maybe he wanted to make more money. I don't know. So unethical. And I've seen residents train. They have to train to do forceps. So they'll put forceps. I remember one woman, young, first birth, it was when I was a midwife at BI. And they were on the door, knocking. She'd been pushing for 4 hours. They were harassing to put blades, forceps on this baby. And I said, just give me a little more time, because now I'm not the ultimate power there. I was a midwife. The docs are the ultimate power. So I'm saying, oh, she's doing really great. And I said, we got to get this baby out. And, you know, once I said to a resident, I'd like to see you do that to your wife. I was constantly getting reported for insubordination. You're not allowed to say that stuff. But I'm like, I was so angry that because he needed to practice how to do, and they do need to practice, of course. Of course. That's why hospitals have those rigid protocols, because they're training first-year residents that don't know anything. First-year residents, July, they all come on. So if you're having a baby in July, watch out. They check, they're like, oh, she's fully dilated. I'm like, oh, really? Because she's 1. They don't know what they're doing. They're learning. They're the first years. They have the second year behind them, a third year, a chief, and an attending that supervise what they're doing, but they don't know anything. And they come on in July. So be wary in July, ladies. No, we're not on July. I'm, yeah.
But a lot of the other ones.
I know.
August.
I'm sorry.
You're the nice one.
I'm nice, but I'm going upstate in August, so I'm working up there. But I'm still taking clients.
Upstate.
Yeah, just not in Brooklyn. Sorry.
Do you ever recommend water
Yeah, I just did.
Or it's usually like another.
So,
And what's the difference between like a birthing pool and a bathtub? Like,
so good question. At 35 weeks, that's on my little list of things to discuss, because I will be the one to bring the pool, because I have a couple of inflatable pools, and then the mom has to know to order the liner that makes that pool, you know, hers and hers alone. So I will usually bring up the topic, and when a woman really doesn't know what to do and she asks me, like, I don't know, should I try water birth? We talk about it. And sometimes I'll say, well, if you're someone who loves a bath, Epsom salts bath, and you have your period, or you're emotionally distressed and you need a break, you take a bath, it might be really, really nice for you. And I have encouraged someone who had a really hard time in the shower. I said, let's try water immersion, because they say that water immersion is the most effective pain control, and you're at home without an epidural. So you're like, I got to do something. And I have only one client who's like, I'm going back to the shower. She hated the bath. We had to learn that by doing it, you know, but most women, the bath will help, but the bath will also, if you go in too early, it will slow things down. So that's why we ended up having the baby by the side of the tub this morning, because she wanted the water.
Why does it slow it down?
If you go in too early, it slows down the contractions, because it dilates your blood vessels, and then the Pitocin concentration is less. Oxytocin, your natural hormone, is less. So yeah.
Do you mind that? Like, do you mind if the mother slows down?
Well, it's not always a good call. Right. It's not always a good call. It can, if someone's in latent labor, it doesn't matter what she does, but if someone's active labor and you've got a baby that's not great, you don't want to slow down labor. And she doesn't want to either. She probably wants to have a baby. But it can be an appropriate thing. I've had people get in and then they end up having to get out because the contractions go away. It's not like it's a terrible thing to do if someone wants to get in the pool, but yeah. Yeah. Yeah.
Oh,
It can make
it like, you know, to put like on both sides of the stomach.
Like you do it too early.
Yeah, it's better that someone's in active labor. And the primate that I said that we put her on the toilet and then she started naturally feeling the urge to push, which I was saying it's physiologic birth, it's what we want. She wanted to have a water birth, but I was very careful because I thought I had one woman when she was fully dilated, she got in the pool, she was in there for 5 hours. Because it slowed, first of all, it takes away the gravity and the pain. So I remember pushing in labor and you're like, I want to get this done. You know, and for a first baby, you might have to do that, but it happens naturally. So I said to this mom who just had her first baby, I said, let's do this. I'll get you to have a water birth. I said, but let me just make sure that baby's, most of it's come through your pelvis. And I was like, oh, it's right there. And we got her, and still 40 minutes later, she waited to have a baby. But that was not 5 hours. That was 40 minutes. So I tweaked it really nicely in that occasion. But the other time when she was there for 5 hours, I was a less experienced midwife. I'm like, she wants to get in the pool. Fine. But, you know, if she wants to be done, which are we going for? You know, so I think that is the factor that might make you. As a doula, you're probably more focused on comfort of the woman. And so it would be natural to kind of lean towards that possibly.
Slow down and be more comfortable, be quicker and more intense, you know.
Do homework midwives have any like tips like for pain management? Like, because it's like in the hospital setting, it's just happen epidural.
And it works.
But if you don't do that,
you're talking to a midwife who almost ran out the door on her midwife because I wanted pain medication in labor. And she just kind of tried to ignore me. And I just pushed my baby out. Okay, if you're in the UK, they make I've already tried. They make nitrous oxide. And at one point in my midwifery career, they were offering nitrous oxide and they would give it. And I brought it to one birth and the woman never used it. And I brought it to another birth because it's laughing gas. And that woman, they didn't offer it yet. And we put whippets in a whipped cream dispenser and she inhaled it. It's nitrous oxide pellets that you put in a whipped cream dispenser. And then you press it and you inhale it, not directly because it has to be mixed with oxygen. It's never going to kill anyone. It doesn't have a negative effect on the baby. So in a way, it's kind of like a safe thing to play with. Once I did that, and once I had the nitrous thing that you put on your face, they have it in the UK in the wall, and in Seattle, Washington, they might. Ooh, I would love to know where. Who? Yeah. So, but it does make you nauseous. It does slow things down. My sister had a home birth in Denmark. She had nitrous. They just don't make it here, which is really annoying. I've had that conversation years ago. I was trying to get them to carry it. Dentists have it. Yeah. Yeah. So the best pain management tool we have is the water. Yeah. Yeah. And doulas, and I mean, when I'm with a woman without a doula, I'm doing a lot of doula work because my only job, check on the baby and write it down, the heart rate. And then like this woman this morning, I was like, I'm going to press on your back. You let me know if it's good. It's like, she's great. And then I pressed on the side, do this hip squeeze. And she's like, oh, the hips. I'm like, okay. She says, no, too hard. I'm like, okay. You know, so I was doing all of that stuff. But I think a lot of women who choose home birth, they know that there's going to be that, I don't want to do this now. I just want to get out of here and be done. And if you tell a woman that they're going to go through that and it's not going to be long lived and they just have to get through it, they do it. But I would never blame a woman who wants to have an epidural because I'm the biggest wuss that ever lived. If you've watched The Business of Being Born, they show me to whine and complain to be humor for everybody who's watching because I'm so bad. I'm like the people they're laughing at.
Question about epidurals. What are the risks?
So, I'm not an anesthesiologist, I'm a home birth midwife. So I can talk around the risks and give you some basic things. So when you give a woman, first of all, it's a blind procedure. So, and I'm a nurse, so I've been there when an anesthesiologist is putting in an epidural. They can't see where they're going, so they can miss, and then you don't get effective anesthesia. But if they're good, they usually get it. It immediately lowers your blood pressure. So before you get an epidural, they run an IV, a full bag of IV fluid in, so you've got more venous volume, so that when your blood pressure drops, it doesn't have a negative effect on the baby. Because if your blood volume dropped and your blood pressure dropped, the baby could also have a deceleration. So that's one of the natural side effects to an epidural. The other thing is that you may not feel an urge to push, which is good and bad, because like I said, when I had the urge to push, I was a first-time mom. It was terrible. I thought I was going to die. It was so bad. And then I had to make up my mind. Well, you're either staying. I prayed to God, like, please take me. Didn't work. It's like, no, you're going to push this baby out. And I remember meeting it psychologically and going, okay, there's only one way out, and I'm going to have to do that. And so an epidural, I don't know if it delays that, because I've never had an epidural. I'm not anti-epidural at all. I think it's a fantastic innovation, but it means you can't have a home birth, sadly. And it means you have to have, that type of birth in a hospital that people are examining you and you're getting an IV, and that's the problem, sadly. That's why nitrous seemed like the perfect solution.
There's no option of having an epidural at home?
No, because you have to be an anesthesiologist to administer it. And
Can you explain what it is? Because that way people understand.
Yeah, I mean, they put an analgesic, which is something that puts your nerves asleep into your spinal somewhere. I mean, epidural space. I'm not an anesthesiologist. And then it puts you to sleep, so you can't feel anything from here down. And so then you don't feel your contractions, and you don't. Yes, and people will say that it affects the ability to breastfeed and tearing, because you don't feel yourself tearing. Whereas an interesting thing about physiologic birth, when the woman's pushing and the perineum is stretching, even I made that like noise, like, and when you make that noise, you're not pushing so hard. You kind of like, which isn't boom. Whereas if you have a doctor telling you push, like push, you don't feel that pain, and the pain mitigates your pushing, which allows the perineum to stretch more naturally. So in a way, it's kind of tough, because natural birth is hard, and I don't want anyone to have to suffer. I think it's better, but you're talking to a midwife who begged to go to the hospital and almost walked out on her midwife to go. I almost took myself to the hospital.
How far were you?
Really close. I was walking distance. I could have walked, but they all ignored me. I went to the shower and I made peace with the fact that I was going to have to push this baby out.
Yeah, that's the most beautiful part. Like when I see within myself, and even with the mothers that I help, that point where you're like, I can't do this. It's like, yes, you can. And once you face it,
you have to face it. And in a way, I'm happy that I've done that. But at that moment, I was happy to get out of there. And my mom had babies in the hospital. She told her doctor, I'm leaving now. I'm going home. Before the baby was out. Transition is like that. It makes you crazy. It makes you crazy. And, a good midwife, I've had 2 people walk themselves to the hospital. All I could do was follow with the chart. I mean, sometimes you just can't do battle with someone, but most people, they walked to the hospital, and I drove along, one was in walking, so I walked behind, the other one was like, I'm going. That's it. You either come or you don't come. I'm like, okay, I'm coming. I can't remember. Maybe the husband drove, but yes. So I will do my best many times to encourage people.
That's the beauty of it.
Yeah, of course. I've been a midwife for 29 years at home. One on Staten Island. I missed by 3 minutes. The baby's born and it's fine. Most babies should be fine. Yeah, she had a baby. She had a baby like the ones in taxi cabs that don't make it to the hospital. It's the same thing. I don't like that. But if you work as long as I've worked, it happens eventually. However, the reason I sleep in my car very often is because I really don't want that to happen. For first-time mom, it's very, very low risk, because even when a woman gets fully dilated, they probably have 30 minutes pushing. Where'd she go? Except the one that said 5 minutes later, she must have gone. Yeah, but in general, a first-time mom has 30 minutes to 2 hours of pushing. So, even if someone starts pushing it, I'm on the way, but I don't like to run it that close. I don't like it. I like to be there, yeah.
Is there any risk with home birth? Like,
there's risk with birth, of course.
With birth itself, that of course, but meaning you tell a doctor, like, you're gonna do a home birth. They look at you like you fell from the sky.
Well, they've never seen a home birth, and they're enculturated to think that you're actually like in the business of being born. That doctor that I went on a panel to talk with him actually, and he said having a baby at home is like not wearing a seatbelt when you drive. That guy who was the head of Mount Sinai. The truth is, if you want all the things that physiologic birth, all the things that home birth offers, you should choose an experienced clinician. And also that experienced clinician is going to be able to decide if somewhere along the way, like my para 8 who had a cesarean, it was so depressing. But I'm sorry, I can't argue with the fact that this baby had distress. We've got to go to the hospital. So we went. It was heartbreaking. 7 babies she had vaginally, and the 8th one with a home birth midwife, I had to take her to the hospital, and she had a cesarean. It stinks. But you have to be able to make that call. You can't be overly invested in the grooviness of it. I can't. You can. That's okay. And you should be, and that's lovely. But I can't do that because I'm the one that's going to need to make that tough call when it needs to happen. But it's rare. Our home birth midwife section rates are like 1 to 3%. No one is 5 and 10. And the World Health Organization would like it to be 22. They used to say 15. So we have great results because we give women time. And as long as babies are fine in there, we don't rush a woman along because she's not dilating according to the Friedman curve, which is the one that is used mainly in the hospital. But people still, there are good hospital providers. So if you don't want to be at home, I mean, it's really funny. So women who don't want to be at home, they want to be in a hospital, they go in really late. I'm like, so no one's been listening to the kid. No one knows anything. There's no one's been checking in on this person at all. We don't know how the baby's doing. I'm not so sure I think that's great either. I mean, my person who broke her water, yeah, going at the last minute. I mean, if you're trying to break down the safety quotient, here's another thing, like anonymity in a hospital.
Help the mother, like when she's how far.
If you go early, you're gonna get an interview and you're gonna get
That's right.
That's why I'd rather go the latest.
Right. And most of the time you're there for the most important part. I'm not saying that. I'm saying we have to carefully understand what the risks are and really carefully think about it. Anonymity is a risk. Like that woman is my only patient. I'm not a nurse. I have been a nurse at the desk, watching 3 monitors while someone's on break at once. Someone has a decel, everyone goes running into the room. That's not the case with my one client. I'm right here, Doppler in hand, with a relationship. It's very, very different. I very rarely do so many postpartum checks on women and press on their uteri to make sure they're not bleeding. I'm looking at her. I see the color of her lips. She's talking to me. Ow, I'm having cramps. I know what women do when they're bleeding. They feel nauseous. They have extra pain. They start turning white, but I don't just routinely press on women's uterus like that they do in the hospital because I don't have a million patients. I've got one right here in front of me. I'm looking at her. I can read. No, they do that so that you won't bleed, so that they're making sure that the uterus is closing down. But we talked about earlier, the uterus will close down if you get your oxytocin rush and if your baby is not taken to the Kreiselman and it is the opportunity to snuggle on your bosom in joyous relief from having this baby and maybe even start nursing. That you're going to get the biggest oxytocin rush, but you have a doctor down there not playing, but trying to get your placenta and tugging and you're sore and baby's over there. You're like, you're not getting the postpartum that you deserve. But of course there are risks. I mean, that's why I'm telling you, I resuscitated a baby. I'm telling you that, we have to be prepared to deal with that postpartum hemorrhage. But I'm saying that if you allow physiologic birth to happen, I believe that the body, there are protections built into the body that they are taking away from you in the hospital. They're making certain things more high risk. So like I said earlier, if you have a baby that is in distress for a long time, it needs a hospital resuscitation, not the one that I did where the baby was perfectly great, had distress for 2 seconds while it was being born, and I could resuscitate that baby with mouth to mouth and chest compressions that I know how to do. But if a baby has had insult, lack of oxygen for 5, 6, 10, 15 hours, that baby is going to be in a state we call secondary apnea. It's going to need epinephrine. It's going to need a bunch of doctors breathing for it. But I can make that judgment call. My baby has been brilliant. That's why the one that I said, the doula said, I don't think we need you. I'm like, no, I want to listen to the baby. And I'm like, oh, what do you know? Good instinct. This baby was maybe potentially going to be in trouble. So yeah, so you have to be very serious about that. But most babies are really fine. And the truth is, the first one, for all you first-time moms, don't get scared. I have my first baby at home, so I'm not afraid of that. Yeah, and you can do it, and you can do what you feel most comfortable with, which is really what you should do. But once you've had a baby, your body knows how to do it. Your pelvic bones have changed. You have what we call in obstetrics and midwifery a proven pelvis. Baby's going to come out. So we rely on that as a confidence, a physiologic confidence. So she didn't develop preeclampsia. She's not a gestational diabetic. She went through pregnancy. The baby grew a normal size. She pushed it out in a normal time. She's done it once before. The next one should pose way less stress to the baby because labors are quicker once you've done that first one, unless you have a family history. And some people have babies in 3 to 6 hours. I have a client who has every baby in 30 minutes. I barely make it every time. She calls me at the first contraction. I make it. Last time I skidded into home and caught the baby. You know, it was like, in the middle of the night, there was no traffic. No, she doesn't have anything until she has 30 minutes. And 30 minutes and I better get there. And we had 3 babies together. I've made every single one. And once I was on Staten Island and I got there in 22 minutes. And I got there, but you know, no, I don't. When I once had to get to somebody on Flatbush Avenue at a normal hour, like 8 o'clock at night, I went, and I'd read, and then cops pulled me over and said, she's punching, I'm a midwife. They're like, why? Because I might get shot by the police, you know? And in order to have the siren, you have to be an EMS. And I don't want to.
They don't get to midwives?
No. Midwives is the most neglected profession out there. So you have to be devoted. Of course. And you have to be really, really dedicated and not expect a lot of support in the United States. If I were in Denmark, I would be held in the highest regard. Midwifery is like the highest regard profession that exists, more than a doctor. But I'm not suffering because I'm doing what I'm doing. And, you know, I don't need that many accolades to come from, you know. But yeah, I got a ticket last night, 4:24 in the morning. No. I'm like, where are those guys going around at 4:24 in the morning? I was parked at a hydrant delivering a baby. I got a ticket now. I've tried that. Once they told me I had the sign, I made it myself though. And we just got a license plate, but it has no privileges. So the license plate doesn't do anything for you except it says, hi, I'm a midwife. It's so cool. But you don't get out of tickets, you can't speed. So you can't park. So I'll just keep on going with my horn and getting pulled over. And usually I'd rather sleep in my car than drive honky. So if I think someone's going to do something, I may just be close at hand, you know. Guys, this is so fun. I knew this was going to be fun because it's such a small setting, which is lovely. So no, people usually don't unless they have vasovagal. I've never seen that, but a vasovagal is a condition where people faint. That's what it's called, vasovagal, and it's the nerve gets compressed, and they do it when they get anxious or something.
Really? I always, it's a good question. I always feel like
they're having needles.
Yeah, totally.
Yeah, needles.
Did you pass out?
No. I actually have passed out from like holding someone's arm when it was jumping, waiting for that when the paramedic came and like explaining what happened.
Oh, right. Right, but you're not in labor. All right, I had a husband who brought in a good Samaritan, brought in a woman from next door. He passed out. The poor guy was trying to do it. He passed out. He went down in the ER. It was Columbia Presbyterian. When I was a nurse, I'm like, this poor guy's trying to do a good deed. They took him down in a wheelchair. And she had a baby. Yeah, so. No, I've never seen that.
I really almost passed out.
Did you?
Ice on me every time, like ice over my face.
Transition is a wild,
Transition.
is wild.
Imagine I'm pregnant. And he's like, oh, I have to go through that again.
There you go. There you go. Exactly.
They actually told him you need someone to be home as well.
Aw, but people pass out postpartum if they have extra blood loss or they move too quickly. That's the thing.
I think there's also the aspect to give context to anybody who hasn't done it or seen a birth. When we're talking about pain, it's not like, people say like I had 24-hour labor.
No.
They think you're screaming for 24.
No.
That's not. So
It's wicked menstrual cramps, but every 5 minutes. So there is a recovery period. The thing that's the most terrible about labor is the despair. In a first labor is you don't know when it's going to end. You're like, how much longer can I do this? And in a way, the doula or the midwife can play that role with you. And sometimes an exam can help someone. Like I don't do exams, but I knew that woman and mother needed help. So I brought them to the toilet because I knew they needed to know that things were almost done. Because that's supporting someone's emotional, not just I'll never examine anyone. Yeah. Oh, but you're thinking about it.
I spoke to you for about 2 hours. You're amazing.
You spoke to me for 2 hours? When? This pregnancy?
No, just a month ago when I decided I wanted to go home. I'll talk to you after. It's my insurance issue.
Oh no.
Yeah, no, I love you.
I'm not.
I'm like your new.
I'm not. I don't need a fan base, but I don't.
It's okay.
I'm not.
Yeah.
Yeah. It's not my archetype of personality at all. I'm a service person, really. That's who I am. Thank you.
Miriam Wasserla is my because of my own traumatic births. I had to get a doula this round. She told me you need a home birth. Like once we sat together, she's like,
and I couldn't take you?
No, it's not that. It's that I was in touch with your secretary, and because I own a Dallas. Well, I'm 37 weeks now. But if I could have you, I would be more than
Going to labor right now. You have a midwife.
There you go. Can't help it.
She pass you some food, like
hoping not yet. But
but for someone who really wants a home birth, you should get it. I usually don't. Katie usually calls me, and I don't usually refuse.
No, you didn't refuse. You didn't.
I'll do any payment plan that exists on the planet. I'm really unique that way. I don't care.
No, I know. I just wrote to her after she called me today. I was at work. So I may see you. I was gonna say.
We better get started if you're having a home birth. We better start some prenatal care at 37 weeks. Let's talk. Okay. What else? Have I answered some people's questions? Are there more? I wanted there to be an opportunity to write down anonymous questions just in case, but it looks like we're talking fine and nobody, but just because, and then if only one person's write it down, that's not going to work because it was only to protect someone's privacy. So they're like, oh, I have one. Never mind then. What about it?
And I remember a friend, every time she had a baby, they would strip her membrane, she would go to labor, and then
Oh, it works. It's a nice induction technique. Yeah, but my philosophical underpinning is that the body's probably smarter than we are, but if there were a reason that a baby needed to come out, I might do that. But sometimes the downside of stripping his membranes is it usually does work. And if some women loved it and did it every time and wanted me to do it, I wouldn't say, oh, I don't do that. But I have had, when I've consulted with people, I've said, well, here's the downside of stripping the membranes. I do it. You may have a day of contractions when you're not in labor because it does something until it kicks over. So that's the downside, but that might be fine with that person. No, not good. And I'll tell you why. Because first of all, the amniotic fluid in front of the baby's head cushions the baby's head, which makes the baby's descent more free of distress, which is good because that's when the baby can have the most distress as it's descending. So you don't really want to break water. I know that it can speed things along. So again, if I have a perfect baby and the mother's like, can you do something? I'm not going to go, no, we don't break water here. I'm there to help a person. And the head has to be far enough down. The head has to be 0 station or below, because if you break someone's water, I might say to a woman like that wants to move things along, I might say, sit on the toilet. The pressure on it'll pop it. And then that way I'm not doing it to her. It's also the thing that I said before, and it might have been before you come in, where I'm trying not to be in the position where I'm doing stuff to someone that make them think that they need me to do it. I'm trying to let them experience the wonder and empowerment that they had a baby, and everything they felt that they responded to got them that baby. Not because I broke the water, not because I said you're 10, not because I got you up to walk. I mean, it's a wonderful thing when a woman can go, wow, you know, and it's subtle and it's very insidious.
Thing that
Yeah.
after home birth, like it changed their life.
Yeah.
Like so many women have told me that. I'm just like, I don't know, I've never experienced that, you know. Only traumatic experiences in the hospital. You know, it's very, very invasive here, very like everything's
Yeah.
you know?
And I've worked in hospitals. I know. That's why I was excited about doing this talk. And I've worked in birthing centers too. The problem with birthing centers and hospitals is it's protocol based. I started that in the beginning. So every woman is treated as if they have the same risk profile when they don't. So if someone else's water is broken and they're clear fluid and they don't have strep B, you can sit on that. She can wait. It's fine. If someone is strep B positive, you want to move that along. I've had 2 primates who were first-time moms who were strep B positive. One of them was 7 days in labor. Every day I went to treat her with antibiotics. I'm like, I can't leave this strep B for 7 days. This is not good for this baby. She had a baby 7 days later, but I didn't push her labor along. Once I tried to give her castor oil, it worked a little bit. The other one was the one I told you guys in the beginning that I couldn't stand by her. She didn't, every time we tried to encourage her, she stopped laboring. And so I had to leave the room with the doula. I said, we're staying in here. And every 10 minutes I went and listened. She needed to be no one around. So she could just give into her pushing urge for whatever reason, 8 hours to push the baby out, first baby. But that's just something you have to learn from and read. And some, you know, I had another one was that we were all, she had all her friends there. We were all like, you can do it. Great, great. And then I'm like, she's not doing it. I put her in a dark room, same thing, ran every 10 minutes, baby sounds fine, left. She didn't need anybody. People are who they are. Women are such individuals. And, you know, if someone is willing to cater to that individual psyche, a woman can have it's just an empowering birth. She doesn't have to give up her own identity. She can just be who she is. Be good, right? So it depends. Yeah, but we know that already. We stay 2 to 3 hours. I don't take away her oxytocin rush. So usually she doesn't have a hemorrhage. If she's going to have a hemorrhage, it's going to happen when the placenta, in the 3rd stage of, you know, most hemorrhages don't happen after the placenta. It's while it's delivering, it's partially separated, it's not going well or something like that. Then I can treat that, manually remove her, give her a bit, do stuff to her then. You know, that's the highest risk of postpartum hemorrhage. And then we stay 2 hours if everything's perfect. Then the woman this morning, she gave birth at 3:30. At 5:30, I got her out of bed. That's nice because then I know she can walk. She wasn't bleeding. I checked her uterus. She didn't have a tear. I checked that. But I said, I'm happy to get out of bed with you for the first time. She said, no, that's okay. And then she said before, when I was getting ready, she goes, yes, I will. Okay, so she sat up on the bed, make sure she wasn't dizzy. She sat and she stood a few minutes, not dizzy. Then we walked. I took down her, she had the maternity diaper down. We have these like Depends things. They're wonderful for the first 10 hours. Took down, like almost no bleeding. I'm like, oh my God, no bleeding. You're so fine. She walked back to the bed. And by then I had already been there 2 hours and a half and I left. She was fine. She went to sleep. The baby had nursed. You know, we make sure those parameters are met. The baby has to nurse, you know, baby has to be fine, have good color. We do a neonatal exam, weigh the baby, measure, listen to the heart, all the stuff that I would do in a hospital if I were the one taking care of the baby. They sometimes have peds to it, but a midwife can do a basic exam. Yes. So that is such a great question. So it has a long history. I was working as a labor nurse when they started finding out that strep B caused babies to be sick when the mother's water was broken for a long time. So they developed this protocol that they tested in hospitals, where if they gave, some clinician came up with the protocol, if you give 2 doses of a penicillin-based antibiotic 4 hours apart, the baby doesn't get the GBS. And they reduced the GBS, I can't remember the numbers, I've read that so many times, by a huge percentage. So then it became the normal protocol. Again, we're talking about not individual risk-based management. a protocol that a hospital does when anyone is GBS positive. Everybody gets that automatically as prophylaxis to make sure that they will not pass GBS onto their baby. But with my clients, so if I have someone who's GBS positive and breaks her water and is 36 weeks, like I've had, that woman has multiple risk factors and it's her first baby. She's going to be in labor for 7 days. I'll treat her. But I have another woman who has GBS every single time. She has a labor. The water breaks 10 minutes later, the baby's out. We talk about this. She's like, I don't want it. I'm like, I'm not going to give it to you unless, you had developed clinical symptomatology that's going to put the baby at risk. So I have the freedom, I'm not an institution, to make an individual-based risk management about that. So I have treated women with strep B, long labors, broken water for a long time with antibiotics. And I have not treated plenty of women who had quick labors with no breaking water. And I have treated people ahead of time with clindamycin cream to get rid of it. And I've treated people with garlic. And we do all kinds of creative things that women choose to do. And we individualize the treatment based on what the woman's comfortable with. And, if there's a risk to the baby, we'll talk about it. Yeah, so it's not, that's the beauty of being able to make an individual-based risk management call. That's why I practice here. I mean, birthing center hours, let me tell you, 224s and a 12. That was it. Get paid great money. Now I'm on call 24/7. I sleep in my car. I like, you got to be devoted. No, I have one of those little roll-out mattresses. I can sleep in my car. Miriam can't sleep in her car. She's miserable. I have a sleeping bag and blankets but yeah, you don't do it because it's a cushy life. Midwifery is not a cushy life. And it's fine, you have to be up to it. But the midwives that are, and especially midwives who do home birth, we are very motivated by. No. Why?
Why am I asking that? Based on like my last experience, my baby turned blue in the middle of the night from all like we swallowed too much fluid. And
if a baby's,
I panicked so much, but in a second I had a nurse right there, so it was like so nice.
So when I leave, easy. When I leave, before I leave, I give discharge instructions. What I said to my client is, when a baby's not a first baby, it is going to spit up mucus for the first 2 days. When you're not with the baby, put the baby on its side so that the mucus will drip out. Because if you put the baby on its back, it's going to go scare you to death, and it's not going to die. It's going to spit it up. It's going to, but that's what I say. And I've never had a mishap,
It's still called midwife.
Yeah, but I mean, if she were worried that she needed instant attention for her baby,
like within 10 seconds, there was like 4 people. Like it probably would have resolved itself. But,
right?
I panicked.
Right. Yeah.
I don't know where. I guess it was a natural.
Well, they didn't resuscitate the baby, right?
No.
It just spit up some mucus, right? So yeah.
No, but she was already a different color.
Mm-hmm.
So I don't know what that means.
It means the mucus has to come out, and then she'll be fine. Yeah. But yeah, it's fine. The sad thing about a hospital is, like, I'm not anti-hospital. Like I said, if it were Denmark, I'd be the happiest midwife on the earth.
After experiencing so many births in the hospital, I actually am super against the hospital.
Because it's New York. I'm not against the hospital in Denmark. I know, but that's why I practice home birth here. It's a concept. I understand. Yeah, I understand.
Even though I birthed my baby here in New York, I'm totally.
I understand. I'm not afraid of home birth. I had my first baby at home. I only have one, but I'm saying that.
I think it's worse to have a baby in a hospital nowadays in New York. And that's like
I know.
And then,
I know. And that's why we do the practice we do. And all midwives would probably rather have a section down the hall. Rather than transport, but we should be able to make, and ACNM says we should be able to make a good judgment call. You should have 30 minutes to make that judgment call.
When did you start this work like that?
Wow. It's funny because I've lived in a couple of different countries. I lived in France when I was 16. And I discovered a guy named Frédéric Le Boyer. He wrote Une naissance sans violence, which is birth without violence. And I was like 16 and I discovered that book, and I guess it was really a calling. I didn't meet him. I read the book and I was in France. Yeah. And he just said that we should put babies in a bath after they're born because it resembles where they come from. And I just was drawn to it. And I was so young when I was drawn to being a midwife. And then I apprenticed with a lay midwife in Oregon when I was 19. Then I studied in a Texas birthing center when I was 19. And then this is written in a book that I wrote. It's actually interesting. I was apprenticing for a midwife who was a lay midwife. And she had two flaws to her studying preparation. One was she had a shoulder distortion, couldn't get the baby out. So she called EMS. I'm like, EMS? We ain't got time for EMS. Get that baby out. I was like, she didn't have the skill to get the baby out. I'm like, that is not good. So some of those home birth stories come from that. Untrained people.
And the EMS knows all those stories.
And the EMS. Right. And they don't know how. Yeah, well, especially Hatzalah. Not all of EMS. Hatzalah is a specialist in that. We know. But that's also because they have a missionary complex. And I know that because everybody who works in the medical field has a missionary complex. We're saving people. Even me, I'm sleeping outside people's houses. It's just part of our makeup. It's good and it's bad, but you have to tame it. And you have to tame it too. You can't be too godlike when you do that. You can't be like, yes, we're better than all the other midwives. Like Hatzalah is like, we're better than that. It's a disease that everybody who does this has to humble themselves and just, like sometimes I'll do something and another midwife won't have done it. And I'll think inside, I'm like, no, not going there, not going there. It takes a lot of maturity and you have to do that. But anyway, wait, there was something else I wanted to say, something. Oh, so then this midwife, so I watched that. And then another one when I was working at the birthing center as a lay midwife in Texas, this was how they treated people who were hemorrhaging and needed an IV. They didn't have the right. They were lay midwives to start an IV. I'm like, how hard could that be to learn? How hard could that be? But I've always been good. No, they're lay midwives. They didn't have skills to do that. So I was transferring a woman, pinching her nipples and saying, stay awake, stay awake. Oh yeah, that's really good. Just give her some IV fluids for goodness sakes. And so, I'm like, I don't want to work like this. So I started in lay midwifery and in states where that was legal. And then I decided, no. Why wouldn't I learn how to start an IV if I can just throw in an IV and someone's going to be fine? So I learned that way too. Like, I don't want to be that midwife. I want to have training. I want to be able to do a shoulder. That's why I didn't leave the birthing center till I'd had all those. I want a postpartum hemorrhage, I want a resuscitation, I want a shoulder dystocia, then I'll leave. Because like I said, fear is very powerful and anyone can fall under the spell. I can fall under the spell, but I've learned not to. But it took a lot of maturity and a lot of like honing your spirit and knowing because sometimes you think, oh, fear's a motivator. It's bad stuff. It makes things happen, I mean, a certain amount, you need to be conscientious, but when it turns over into just consumed by fear, it's not good. It's what makes you have adrenaline. It's probably what caused the first Erb's palsy I ever had, because the fear was so great that I pushed to deliver the head with superhuman strength, to try to get that shoulder out of the baby. It's not coming. And then the more experienced midwife delivered the posterior shoulder. So yeah, it is. But really, most babies are fine. And most babies, if you leave it to the wisdom of the woman's body and stop interfering, they come out. And don't make women so afraid, because a woman who's afraid, it's harder to be powerful when you're afraid. It just is. I can't say there's no risks. There's risks, but part of what I feel we should do is not be fear mongers. Let's look at the risks. Let's break it down. Let's not just keep a little corner in denial. Oh, I don't want to think about that. I don't want to think about that.
But there's also risks in the hospital.
Of course.
What are the risks that are
It's a huge conversation. Like I said, I am an experienced midwife. I can manually remove a placenta. I'm pretty sure, but I'm also hesitant to say no one has ever died of a hemorrhage at home. There's zero maternal mortality at home. Guess what? There's not zero maternal mortality in hospitals, and it's caused by post-cesarean bleeding. So they do a cesarean to save the baby. The mother goes home. She bleeds internally. She dies. That's the only maternal mortality is from that. So, no one's talking about that, about the 34% section rate. No one's talking about getting that down so that in a hospital, they're still having their missionary complex and saving babies without looking at the consequences. Really, it's really involved. Sometimes a cesarean section is great. A lot of times it's just not. It's not helpful. Breaches, they shouldn't be sectioning all breaches now. It's terrible. Breaches can be delivered in Germany. The midwives are in hospital. They deliver breaches. In Denmark, they deliver breaches in the hospital, and you need some skill set, and they have it. Here, because of one study, they didn't teach anyone to deliver breaches. There's a Canadian doctor. He's French. He speaks French. He's not French Canadian because I know he speaks French like a French person. So he's French, but he's trained in Canada. I know him. His name is Dr. Sylvestre. And he does breaches. He works at Weill Cornell now. Maybe he doesn't because they're so conservative there, but he was doing breaches forever. Primate breaches. If you have the skill set, you can do that. But here they just section them. And then a woman is post-surgery. She has surgery. That's huge for her entire reproductive future. And especially in a community like yours where people are going to have 8 kids. You should not be incising someone's uterus. You're causing risk for further, more placental adhesion, more abruption. You're actually you're increasing the risk of someone by doing a cesarean. So you have to think about it very, very carefully and not do a C-section if you've run out of ideas, which is, I've seen it, the golf games and all that stuff and just it's so difficult. And it also, this is something that the medical establishment is not really willing to look at, but it also makes a woman feel less than. And then who wants that? And who wants to have to dress that like you've had a cesarean? You're like, oh, I wish I could have. But then you have to have a VBAC that comes with more risk. So now they put you in a risky position. So interestingly, I just had a scenario where she had a baby with me. All her other babies were in the hospital. And when we took the history at the first visit, she said that on one of her babies, it was little and that it was kind of a little growth restricted. She had little babies, and this one was 7 something. It was perfect. That she had, they told her that it was an abruption, but the baby was fine. I said, okay. Now, this baby, I was with her. She was in the tub, and she's having a contraction. And maybe I thought the water was broken. I can't even remember. It doesn't matter. And I see bright red bleeding come out. Now, bloody show usually looks mucousy. It's thick. It sticks to your leg. It's different stuff. It's mucousy. And she's having bright red bleeding with every contraction. I'm like, I listen to the baby first thing, because if she's going to have an abruption, the baby is not going to get its oxygen. If she has a full abruption, baby's going to feel distressed. Now, I knew I could get that baby out because she's probably 9 centimeters. By now, she's had 8 kids. She knows me. She trusts me. So I can go, you got to push this one out now. No, I listen to the baby. Kid's fine. I'm like, I watched a little more. I said, okay, I'm going to check because there's a little bit of blood. I just want to check. And it was a weird blood. It was like a flat thing. I checked. She was like 9 centimeters. I just held her cervix out. I didn't tell her to push. I just left her alone. But because she was 9 with the little lip, I thought maybe she was pushing on the lip and tearing the lip. And that's where the bleeding was from. I said, I better investigate. I asked her if I could check her. I didn't just go invading. She said, yeah. And then the baby came down and came out a few seconds later. And the placenta had a clot on the back of it. And we think that that's what she'd had on the other birth. And she said, could that happen again? I'm like, it's so hard to know. If you have an abruption and you're walking down the street and you're bleeding, pouring out blood, you go to the hospital. And Miriam had a client that just had that. She wasn't even term. She was 20 something weeks. She woke up in a pool of blood. She went to the hospital. She ended up and Miriam transferred her. She had prenatal care with the hospital. She had a baby in the hospital. No, weeks. No, not after the birth. She was pregnant. And then she went to the hospital. She stopped bleeding. They sent her home. I don't know what they did. They may have measured the thing and had her come back. She continued her prenatal care and she had a fine baby in the hospital. Things can happen. Anything can happen. And a hospital can't always cure them. If you have an abruption on the side of the road, you either make it there in time or you don't. If you're walking down the street, your baby's breaching, you have a prolapse cord, there's nothing you can do. You can try, and we absolutely will. And there's always going to be, sadly enough, that like Marsden Wagner said in the movie, there's never going to be, the perinatal morbidity and mortality rate is never going to be 0. Having a baby, all babies aren't going to make it. But we don't want to ever think that. We're mothers, we're caregivers. So
Also, like, you know, the
we're
risk of crossing
human.
the street, the
Yeah.
risk of flying in a car.
Yeah.
We inherently
Flying in a car,
live-
chitty chitty
Sorry.
bang bang. I'm just having fun with you.
You got it. Flying in an airplane, driving a car.
Yeah.
Like it's an inherent aspect of life, and this is where I think a big part of our community we like. Right, no, but like we lean,
especially with the drivers around here.
We lean into like, you know, a higher power, having a son, having God to like, you know. Yeah.
And what you're talking about is a faith-based explanation too of what I'm saying. It's like trust is the opposite of fear, but you still have to know.
Yeah.
You still have to converse with that. You can't just be in a little bubble. Then you get hazed. That's why all those new midwives get hazed, and that's why I don't want to work with them, because they bring their naivete to me, and I have to wear their hazing, and I'm like, I don't want to do that. I've been hazed enough. But I've trained many midwives out of a sense of duty and obligation to create midwives that are comfortable with home birth. And it's great. Tanya Z, one who moved to California, Janessa, who was a lay midwife, and she got a degree. So for a while, I was doing a lot of that.
How many years in?
I'm naturally a confident person. So I'm naturally not afraid. I'm very good in an emergency. So even when I was young and my sister's friend got hit by a car, I'm like, get a blanket. Like that's why I'm doing this. I always had a feeling for what to do. But I feel more capable now of making a very, like I was saying before, I was confident to transfer that baby was having distress. It needs to go transfer. But now I feel like my judgment calls are honed. It's more like I feel like with the woman whose water was broken, that kid was torturing us for weeks. She thought she broke her water 2 weeks ago. The baby was vertex. I'm like, great. This was Friday morning. Saturday night, as soon as Shabbos was over, I said, we should talk, because she thought she'd broken her water. She hadn't. She'd beat on herself because the baby turned head down, busted on her bladder. She'd never had that happen before. We figured out she had no leakage all Friday, all Saturday. I'm like, you probably beat yourself.
And you didn't check? Did she
check?
Like the swab?
It doesn't matter. I could have, nothing was leaking out. She had just had that happen to her. So I can check. I can look under a microscope and check if there's any fluid.
Right.
But I have to have the fluid check. So we were watching her. She was precautions, no sex, no baths, so taking her temperature as if she had ruptured. She didn't. Then Saturday night, I go back to check on her, to visit, to make sure the baby's fine. The kid's breech. Then the next Friday, I said, we're on Friday prenatals now. The kid was vertex again. I'm like, so this kid had us wrapped around his finger. So when she actually did break her water on the 20th at night, I said, I'm coming over. I want to see what kind of position this baby's. That birth demanded so much time, energy, investment. And I had somebody else who, like, she called me. She said, I'm fine. I don't need you yet. I'm like, raced over to house. She had a baby 10 minutes after I got there on the 12th. I didn't do anything. I didn't have any refined judgment calls. I didn't, nothing. Kid came out. So it's not that often. That's how quick her labor went. She didn't see that. She was amazed. Sometimes. I mean, she's always been kind of quick, which is why I told her to call me early in case I was shopping in the Bronx or something, which she didn't, but it happened to be 2:30 in the morning. So I just came over the Williamsburg Bridge and I was at her place in like 10 minutes. And she couldn't stop saying to her sister, I can't believe you knew it was time to come. Because for as many years I've been a midwife, we do telephone triage. We listen to people on the phone. And the woman who broke her water on the 20th, I came over and she's like, do we need to fill up the pool? I'm like, she's not even in labor. But I didn't want her to get discouraged. So I said, no, it's still early. The baby, I listened to where the baby, I knew it was not ready. So I'm gonna go sleep in my car, and you let me know when they get close. When you have regular, she wasn't having regular contractions, but I needed to go because her water broke, and we didn't know what the position of the baby was going. So I made sure the baby was set down, everything was fine, and then waited for her labor, and she finally had the baby 24 hours later. Yeah, she said, "Oh, I'm fine. They're every 3 minutes now." I'm like, 3 minutes? Well, I told her to let me know when she has anything 10 minutes apart. And another challenge with your communities, you guys don't like to see blood. But if someone has bloody show, usually the baby's going to come within the next 24 hours. So if I knew someone had bloody show, I wouldn't go to the Bronx. With the black underwear and all that, I'm like, that really is hard for me. But okay, I know you're like, I have a client now. I said, I know you're not going to look. She's like, I'm not going to look. I'm like, I know you're not going to look. But if you happen to see by accident, will you let me know? No, because I understand what it involves. I'm like, if you happen to by accident see, let me know. But that's a really good clue, but not everyone gets it. It's a really good clue. Something might be happening. And usually someone has a show there, but they'll have the baby in the morning. They have a show, they wipe, they'll have the baby that night. So then I'm like, I'm staying close to home. But
this was so it's funny how much the discussion has to be had on the like fear, this and the worries and the
you have to.
But then when you're in it, or whether you're the mother or whether you're experiencing it, the magic, the beauty of it, the like breathtaking aspect of this child, just it's just so special.
Miraculous.
That,
I know. It is even, and after this baby was born this morning, I was so relieved. I wanted to cry because this kid had us tortured for weeks. Yeah, it had. I mean, we didn't know what it was going to do.
My friend had a baby this past year, and then she told me, she sent me pictures. This is the best part. I was like, this is the worst part for me. I would have. She showed. What did she send me? Videos of her kids all piling
on the bed.
After birth.
Yeah.
This is the best part. I said, that is like the part why I don't want to get
That's why you want to have a break.
That's why I want to be in a hospital.
Yeah, the kids are different for everybody.
And for her, that was the most magical moment. Something she said, it was.
Well, this one, none of the kids were awake when I left. I left at 6 a.m. She had the baby through today. I left at 6 a.m. Nobody was awake. Yeah.
For me, that was horrible.
And women are allowed to be individuals. It's beautiful. Yeah. But they probably wouldn't jump on you right after. It's probably the morning. Like this morning, I left. She had a baby at 3:33. So she was already, the first 3 hours are the most intense, the cramping, the nursing, the bleeding, by 3 hours, she was settled in bed and her kids hadn't awakened yet. And they were going to wake up to a new baby. What an amazing feeling.
Your teenage daughter says, I don't want you to have a home birth.
I don't know. Oh, wow. That's tough. She feels protective, or she doesn't. Teenagers, they don't necessarily. Yeah.
I was like, how do I go about it? Like,
yeah.
She's very uncomfortable. I'm like, what do you have to do with this?
This is probably stressful for her.
I think
because
she doesn't know.
It's stressful for dads too, because they feel like then they have to play more of a role. It's much easier to just go let the hospital do it.
Oh, on the contrary, my husband is so supportive. He's at the hospital and he feels he has to be advocating and there for me the entire time because everyone else is not. So he feels he's so for a home birth. He's like, adios. I'll be upstairs sleeping.
Hey.
Let me know when the baby's born.
I know, I'm just joking around. Yeah. That's for primates. Yeah. Because if it's going to be long, we need them to be restored so they can be the second shift. That's fine. She doesn't have to. There's no perfect way to do it, but I can say that a hospital is going to do active management of labor. I can say that with absolute confidence because I've worked in hospitals for years and I know what they do. And I can say that the best chance of having physiologic birth is out of that environment. And that's what I chose to be the topic, not like hospitals are bad. Birthing centers.
Like a place that they have, whether it's for space, whether it's for kids, whether it's whatever it is.
But
she chooses to do it in a home, but not there.
And I would say this is the most natural, amazing thing. So she's like, okay, maybe.
Well, you would greatly influence her if you did.
Yeah.
But maybe she doesn't want to see it. She's a
Like
teenager.
I have that separate house, so.
Right.
It didn't even be in my home, it's the one downstairs.
Right.
Separate entrance, I told her already, don't worry, like, you'll probably be sleeping, it's gonna happen in the middle of the night. Like, do you think there's like something about it that the babies usually come?
Yeah, I say that
For Shabbos? Most of my babies.
full
come
moons are a
Shabbos.
thing too.
Right, full moon.
I usually say labor starts usually, but it's not absolute. You can never be sure of anything in obstetrics. When there's people say, I don't think you're ready to have a baby because you're 3, and then 10 minutes later you have a baby, they're wrong.
Okay.
So forget about the certainty. I have no certainties, but I have seen a trend that more labors, that's right, start between 10 p.m. and 10 a.m. So if I want to take a trip and I have somebody who's like due in a week and I want to go like to Jersey to shop or something, I usually wait till 10 a.m. If I haven't heard from anybody by 10, probably nothing.
Oh, wow.
That's my guideline. It's not absolutely true. I had someone, I was an hour away. It was Shabbos. She was in Borough Park and I was an hour away. And she called me like at 5:30, right before Shabbos. I said, it's one of those Shabbos check-ins. She just wants to tell me something might be happening in case I need to call you tomorrow. She said, I don't think it's really happening. They're 3 minutes apart, but it's really light. I'm like, okay. I said, let me know. I got him in Borough Park. I said, I'm on. She called me. I said, I'm on your street. She had a baby like 20 minutes later. No, it was Friday night. It was probably Shabbos. They were probably lighting candles while she was pushing her baby out. It was like that. You just can never know. And when you think you know, you're going to get hazed. I'm telling you, it's a rule. Pregnancy, it keeps you like that. Is why I'm grateful to be a midwife, because it keeps you so humble. Once you start becoming that person who's like, yeah, I know what I'm doing. Goodbye. You're going to get hazed. Watch out. Yeah.
It is magical.
Oh, I loved that it was a small group because I was a little nervous about public speaking. Look, I made all these cards and I didn't sleep last night. I'm like, just in case I start, I need a card. And I didn't need any of them because you guys made me so relaxed and such great questions.
You're awesome.
Oh, it was so fabulous. And Miriam was like, oh, I don't want to do that talking. I'm like,
This is the first time bringing it? Like,
yeah.
No, I just felt everything aligned with my life. With her. I don't know what is going on. No, it was very strange. I heard Cara like for the past several months.
From other people that have had babies with me.
And I reached out and then, wow, literally.
I think I know your name, but I'm not saying anything because I'm violating HIPAA if I do. I'm no HIPAA violator.
Wow, so special. I thought maybe this was like, oh, this is my first time coming. Welcome.
And you didn't know I was speaking?
No, I came because you were speaking.
You, okay, okay. Oh, let me get rid of this.
She told me that you were speaking. So
Lovely.
I made it a priority.
Well, thank you for coming. It's been really fun. And anytime.
You both
Yeah.
Living Chassidus.
So nice.
Yeah.
Well, you are awesome.
Yeah.